Good afternoon, everyone. My name is Susan Lynn Osterly, and I'd like to welcome you to the 13th convening of the Low Value Care Task Force. Before we get started, I'd like to go over some housekeeping items. We would really appreciate it if you could add your affiliation to your Zoom name. To do that, you click the Participants button at the bottom of your screen to open the list, hover over your name, and click on the More drop-down button. Then click Rename. And then we ask that you include your first and last name followed by your affiliation, such as the example here, Jordan Clark, VBID Health. We also ask that unless you are speaking, to keep your camera off and yourself on mute. Now, we'd like this meeting to be as interactive as possible. So when you would like to ask a question or make a comment, please raise your hand. You can find the raise hand function under reactions. Some of you, like myself, might not have a reactions button, so down at the bottom of the screen, you would click on More, and then you would find reactions. So when it's your turn to speak, please remember to unmute yourself, and then when you're done, please lower your hand. And now, it's my pleasure to hand things over to Mark Fendrick.
Thank you, Susan Lynn. Hello, everyone. Can you hear me okay, Susan Lynn?
Yes.
Great. Thank you for your expert leadership. I can't believe that it's our 13th convening. When Mike Chernew came to me with this idea about get people to focus on unnecessary, wasteful, or low-value healthcare, I never thought that this would really be one of the most actionable and engaged groups that we've had. Unbelievable progress over the years, and really looking forward to keeping this going. We have another great agenda today of provocative speakers that will hopefully get all of you members thinking about what we could do to measure and eliminate low value care, to hopefully create headroom, which is the whole goal of this idea of low value care, so we could cover high value services more generously. And you all know I'm going to be very brief. There's been a lot going on in the world of high and low value care, most notably for us in the world of VBID, the recent Braidwood versus Beshara decision that potentially could undermine the preventive care provisions in the Affordable Care Act, which is why those of us in high value care have largely been focusing on chronic disease services for the past 13 years, because the ACA required all non-grandfathered plans to do what's right in that eliminating cost sharing for high value preventive services that has clearly led to an increased uptake in this care, and very importantly, has disproportionately benefited in a positive way underserved communities, those low incomes, chronic diseases, and communities of color. And because we want to cover things more generously, and as Mike likes to say, if you buy more things that don't save money, you won't save money. We have to figure out a way to pay for it. And instead of raising premiums, or even worse, raising cost sharing in blunt ways like deductibles, which decreases the use of most high value services, we wanted to focus on the removal of care that at best don't make people healthier, and at worst sometimes causes harm. This meeting, I think, is particularly worthwhile in the fact that some of you might have heard that the American Board of Internal Medicine Foundation's Choosing Wisely initiative is winding down next month. And the torch needs to be passed, not to a single organization, but organizations like the Low Value Care Task Force to move this forward. And it's been really terrific through these 13 convenings over 7 years in working with so many of you from the payer side, being plans, self-insured employers, or employer coalitions, our partners that work on a statewide level, such as VCHI from the Commonwealth of Virginia or the Washington Health Authority that you'll hear from today, and our partners like MedInsight at Milliman and Health at Scale. And so it's really been, it takes a village. And I'm hopeful that even though Choosing Wisely is going away, that we'll be continuing our ability to bring these key issues to the fore, make progress in the elimination of low value care, and continue the march to coverage high value services more generously. Next slide, Susan Lynn, please. So the task force goes on. Here are our two sponsors for today's meeting. I thank you, Johnson & Johnson, primarily Silas Martin at Janssen, and our friends at Pharma, Sammy Doherty and Ali Lapidus there, who continue to help us move forward, not only through the task force, but work at the VBIT Center as well. And we're happy to say, next slide, that the task force will live on. The 14th convening October 11th, 2023. We are 90% likely to do this virtually one last time, but there is a chance that if things go in a certain way that we may consider an in-person convening. I think that's going to be more likely to make Beth Bortz happy the spring of 2024. Next slide, please. So Mike and I are extraordinarily thankful that we're 13 for 13 in having our close friend and colleague, Cliff Goodman, moderate these sessions. And with that, Cliff, the day is yours.
Thank you very much, Mark, and thank you all. Welcome, as you've heard, to the 13th convening of the Low Value Care Task Force. We've got a packed agenda, and I'm pleased to kind of share that with you now. We're going to do a few introductions, in particular of new folks. We're not going to go through the whole set of participants, but we've got about a half a dozen folks or so whom we'd like to self-introduce. We'll provide a couple of short member updates. I know Denise is on the board for that and others. Then we're going to move to improving patient care by reducing unnecessary procedures. Aaron George from Meredith has a great presentation to share with us, really thought through very, very carefully. We appreciate that. Aaron will be followed by Beth Bortz, who's going to give, I like to say an update, but there's always like something new and substantial out of Beth from VCHI with regard to no value care definition and proposed list. This is pretty far along. Want to hear more about it. Then out of HCCI, we're going to hear from Aditi Sen on the National Low Value Care Report. Some very interesting findings in there, particularly regarding prioritization. You'll see what I mean when we hear the presentation. We'll take a 15-minute break, after which David Kim from University of Chicago is going to provide some lessons learned, in particular from low-value prostate cancer screening. It's a very good example of how to do this right and what we've learned along the way. David will be followed by Michelle Rockwell out of Virginia Tech Carolyn School of Medicine, Tech, and she's going to present on removing low-value care to create headroom, as you heard Mark Fendrick just mention, for expanded coverage, and in particular, the case of cervical cancer screening in Virginia. So we see we've got some kind of high-level overall overview stuff, as well as some very concrete examples with regard to lessons learned, and in particular, looking at a couple of screening procedures with the prostate cancer and cervical cancer. We'll talk about some next steps, and then we'll adjourn. So with that, I want to go to our next slide and some self-introductions, and I can't see everyone who might be here, but I think I've got Randa Deaton and William Kramer from PBGH, if I'm not mistaken. I wanted both of them there. Randa, I think, was introduced before. Randa, are you, I think she did say she was introduced last time. Okay.
Yeah, hi, Cliff. Thanks for the introduction. I am the Vice President of Purchaser Engagement at Purchaser Business Group on Health. I replaced Lauren Vella. I know a longtime member of this, and everyone's a big fan of Lauren, including myself. So anyway, we're delighted to be a member of the VBIT group. And I know my colleague Bill is on as well.
Oh, Bill Kramer, a quick hello.
Hi, Cliff, and hi, everybody. Appreciate the opportunity to join the group. I'm Bill Kramer. I'm Senior Advisor for Health Policy at Purchaser Business Group on Health. Work primarily in the public policy arena, both the federal and the state level. Just want to express appreciation for the great leadership that Mark and Mike and all of you have provided over the years to push this very important idea in both the policy arena and by purchasers like PBGH members and others.
Well, thanks, Bill and Randa. PBGH continues to be well represented. I'm wondering if Ira Klein is on. Ira Klein, we're revisiting with you if you are there. Not sure I see Ira just yet. Ira is probably going to join. Drew
Oh, can you
Olive.
hear me?
Yes,
Good.
now we can, Ira. Good. Glad I recognize your
Fantastic.
voice.
It's so nice to be here, and I apologize for some of my absences. I am now the VPMA for Pay Relations at Tempest Labs, and I really very much relate to the low value mission in a new way, because it seems that genomics is following Moore's law, actually even more aggressively. And so now it's not going to be a problem to have the genome sequenced. It's just going to be a problem to get the therapies.
No kidding. Well, we'll have to deal with that and make sure that they're evidence-based, of course. Thank you. Great to have you back in with Tempest Labs. Thank you. Drew Oliveira, I think, is also new or reappearing. Drew, are you there? Not sure Drew's here. If not Drew, then from Arnold Ventures, Lily Ellis. And then if not Lily, I know Warren Tays was going to join as well today. Warren, are you there? Some folks are going to join a little late, I think. Okay, not hearing them just yet. We'll move on. Thank you very much. If they do come on, let me know through the chat. We'll make sure that you can say a quick hello. Wanted to move over to Denise Giambalvo. Denise, I think you've got a quick report on opioids and back pain. And I think you may be accompanied by Mohammed Said as well. Denise?
Yes, hi Cliff, thank you. Happy to be here updating on our low back pain implementation collaborative funded by Arnold Ventures. So we're bringing this to a close. So I thought this would be a good time for us to kind of talk about our secret sauce and how we were able to get health plans, purchasers, and providers to work together. And so it was really important that we set the expectations up front. When we were recruiting the participants, they all had to sign off that they were actually going to take action as we worked together in this work group. And we also decided very early on that we would run this in a similar manner as IHI in their collaborative model. And so that was another really important piece for us to determine exactly how we would transpire over the many months, about 14 months that this took place, and the cadence of the meetings, and starting out with us doing a lot of the talking and moving it to the participants talking to each other over time. Really made a big difference. Curating the information and making sure that we were being very targeted with what we were providing so that we wouldn't get lost in the minutia, and keeping it really simple. So what are we not doing, right? So that the aim was to reduce the amount of low value care being delivered, specifically, opioids, the prescribing of opioids, and unnecessary imaging. So keeping that aim at the forefront for all of our meetings. That also helped us with coming to an agreement on a care pathway. It made it easier. It doesn't mean it was easy. So we reviewed it and we reviewed it again, and there were probably about 35 iterations of it over the period of about 5 months. But we reached an agreement among all parties, and then we were able to set our actions based on that pathway. We also invited people who were very innovative in this space to present, and that helped to inspire thought and for some of our participants to think about collaborating in a different manner. And then I think, most important was the team running it. So our team internally and how we work together and that we respected each other's strengths and allowed those to shine, and let each other step forward and step into those strengths. And so that we just worked well together, and I think it really showed in how this all went off. And then we always kept equity also in mind and as a part of the discussion. And so I think this is, one example of how that played out, which is a patient education piece that we did in 6 languages, including English. So we looked at the top 5 languages other than English spoken in Washington and got this translated into all of those. And so it's a template that can be adjusted to fit the organization that's using it. So appropriate for providers, health plans, and purchasers. So thank you for allowing me to give that update.
Okay, and was a colleague of yours also going to add some information?
No, not
this time. Okay, thanks. Denise, the matter of equity, my sense is that has really experienced an upswing in just the last couple of years. And you did mention it from the standpoint of language. What other kind of thoughts might you have about addressing the equity and disparities issues as you experience this particular instance with opioids and back pain?
Well, I can say that one of our providers has done quite a bit of work in their EHR system. So creating prompts for the physicians to help with that, with equity, and also putting things in different languages. So that's one way of doing it. We had a union trust with a large population of non-English speakers who are more concentrated in a certain part of Washington. So they met with their health plan to talk about different outreach, and also who else they could partner with, because there wasn't enough providers in that part of the state to serve their population.
Okay, good. Thanks very much. Thank you. I know that, and by the way, this is just a great kind of module of experience and best practices that I think we brought forward and taken beyond opioids and back pain, of course. So thanks very much, Denise. I know that Carol Huffman has an update that she wants to share with us. Carol, are you there?
I sure am, and
Great.
thank you. So Mark asked if I do one of my rapid fires, so that's what I'm going to do. After the summit a couple weeks ago, I was really inspired. I thought that was an excellent summit focused on the health equity topics. And so I asked myself a different question. I asked myself, what would I do if I wasn't being paid to do it? What would I still do in this healthcare space if I wasn't being paid to do it? I think that's a really important question as we think about what our compass is. And one of the first thing I would do is still get the word out about low value care versus high value care and spending that bucket of healthcare money wisely. I'm going to do that next week. I've got a panel of friends, some folks who are on the call today, coming to my panel for one of the MPH programs at Columbia University. And I think it's going to be really lively. But you want to make sure you get in front of the people who are coming out from school and are trying to make a difference, and tell them what's working well and what failed, and really start to drive these concepts home in a very practical way. Stop talking, start doing. I would continue on with the Women's Health Initiative. So, we talked about women's health, Black women's health, maternity bundles that actually aren't just financial, but actually have the how, and the how that enables the pregnant woman to actually take care of herself. So it's not just this, back end financial model to save everybody a bunch of money. You actually are looking at the how. I would, do that end to end. So the IVF, the menopause health, CHF, obesity, diabetes, orthopedics, so much goes into end to end women's health. I would keep working on the clinical trials access. So there's, the FDA is really looking at ways of health equity, more people access to clinical trials. There's a way to do it, but what it really involves is bringing a new set of stakeholders together and doing it as a new method of clinical trial design. So I would keep working on that. I would keep working with the community hospitals. There's so much that community hospitals need in order to catch up and be able to give the care that they need to give around behavioral health, high performing networks and integrating those networks. Community hospitals really need that. Everyone needs that. Community hospitals need that. Of course, I'm in New York, so I'm sensitive to that. So that integrated care team model that involves more of the stakeholders, I would keep working on that. And I would keep working on dental health. Oh yes, dental health. So
Anything else?
One last thing is dental health, because I'm in love with this new dental health company that actually transforms people's lives by doing a kind of a different procedure that does those snap-on teeth, but it's an affordable model. And they really are targeting hardworking people who, are at a point in their lives. And it not only helps with people's, smile, it helps with their A1C. So I'm really super excited about, those types of programs. So there's my update, Cliff.
Well, Carol, you're going to be a busy person if you're going to follow up on all these things that you're going to keep on doing. Very impressive. Gosh, equity, clinical trials, dental health. I mean, dental, good gosh, talk about an unmet need that has huge implications for the whole body health and quality of life.
There's so much high value care out there. We have to make room for it and get it done.
We hear you, and we're glad that you're sticking with us. So thank you very much. I want to pick on Jason Spangler next. Jason, I know we heard about your transition to IVI last time we met. Anything you want to add with regard to updates, new information, Jason?
If I don't think we have a lot to add, probably the only thing I wanted to note is following the summit on health equity, we had our own method summit that focused on health equity and economic impacts. And so that was mainly geared toward incorporating health equity into value assessment and HTA. So a little bit different than value, than value-based insurance design, but obviously some parallels. We had a panel at the VBIT summit, that Jen Bright from our team was participating in. So just if people want additional information, be happy to share that. Just a couple notes around that. One is one of our themes is that there is no value without equity. And so that is how strong we feel about it, and what we've heard from people in this field, from our experts and our steering committee and key informant interviews, that if you're actually looking at value and you don't have equity, then there's no value there. And so that's how key that health equity is to all of the value discussion. And then the final thing I want to say about that is, I don't know how many folks are following, the Inflation Reduction Act and the draft guidance that came out a few weeks ago, and the comments on that were due last Friday. But one of the things just to note as we think about equity, if you look at CMS's strategic plan, it is the first pillar of their strategic plan is health equity. And so anything we do around health equity should be, something that CMS, whether it's Medicare, Medicaid, whatever, they should be enthusiastic about and want to incorporate as well. And so, so as we're thinking about that within, all the value discussion, they should be a willing partner on all this, because this is one of their strategic priorities.
Well, Jason, thank you very much. And I'm saying good luck, and not sarcastically, good luck with promoting there's no value without equity. It's a great slogan. It sounds good, but when you try to operationalize that, you're going to have a bunch of hurdles insofar as personal health versus population health. But we're with you on that. Thank you, Jason.
Thank
We have
you.
one more update. Thank you. One more update. I think Mohammed Saeed wanted to comment about this is not a wash thing. This is something else. Mohammed?
Thanks, Cliff. Hi, folks. I'm Mohammed Saeed. I'm the Chief Medical Officer at Health at Scale and also a physician at University of Michigan and Ann Arbor VA Hospital, where I am today in clinic. Just wanted to update the folks about what we've been doing at Health at Scale. So we're based out in California, team of machine learning folks working with some of the best folks that also in clinical healthcare. One of our latest efforts have been to look at the all payers claim database from Virginia. So first of all, a big shout out to Beth Wertz and to Mark Fendrick for making that connection for us, and for Beth championing, trying to use more innovative ideas like machine learning to look at data in large databases like APCD. So we actually did a pretty comprehensive analysis on APCD. We looked at FWA using very nuanced machine learning and look for anomalies that would stand out, as well as be not consistent with the evidence-based practice patterns. And we found that we were able to break down FWA and APCD both from a plan reimbursement as well as patient responsibility. So here we're trying to measure the impact, not just on the plans, but also what are patients paying out of pocket for what is likely FWA type services.
That would be a great advance. That's another missing piece to a big puzzle, Mohammed.
Yeah. And then we also looked at the FWA along the different lines of businesses from Medicare, commercial, Medicaid, duals. And we broke down, what is the estimated percent spend on FWA. We also did it regionally. And, I think this is a segue for us to really maybe start attacking the health equity perspective. Are folks who are from disadvantaged socioeconomic backgrounds more exposed to FWA? So I think that's another area that we are trying to take a deep dive into. And then really we've did a breakdown in terms of different types of FWA, from unnecessary lab testing, unnecessary procedures related to neurologic type testing, and we've also gone to looking for potential wasteful procedures with respect to dialysis and even care management services. So, I think one of the big takeaways for us is all payers databases are very powerful resources that can allow you to have, the best insight possible into FWA. So again, huge thanks to Beth and Mark for making this possible.
And big thanks to you as well, Mohammed. APCDs have been around for a while. We've been talking about big data for years, but it's really encouraging to hear how you're applying AI, machine learning, and other ways to really apply another layer of analytics to these larger and larger databases. That's a great set of applications. Thank you for that. Wow. Well, those are some pretty good updates, I must say. And I don't think we have any further updates, at least of which I'm not aware. So I want to move next to Aaron George out of Meritus. And Aaron's going to talk about improving patient health care by reducing unnecessary procedures. Aaron, I've seen your presentation. You got a lot of great stuff in there. And I think what we're going to do is go about 20 presentation plus 10 Q&A thereabouts. So Aaron, the floor and the screen are yours.
Excellent. Well, thank you very much. I'm happy to have an opportunity to connect with this group and share some updates from an initiative that we had engaged with here at Meritus Health over the past 2.5 years. Briefly about myself, I'm a family physician. I also had served as the Chief Medical Officer at Meritus Health for the past 2.5 years when we engaged intimately in focusing on reduction of unnecessary testing. I have recently transitioned as we are laid the groundwork for a new proposed medical school in rural Western Maryland, and I'm helping to design and build the curriculum of the school, serving as an associate dean for clinical education. So my hats have changed, but my passion for value has not. So I hope I'll be teaching students intently about this as much as I have in years past with regard to focusing on in the clinical setting. Again, as a family physician, value is near and dear to my heart. I feel like I walk into every patient room and think not only about the cost, which is obviously forefront with reduction of utilization, but practically for myself, the less tests I order, the less tests come back to me. And so I have found it just wildly surprising and almost irrational when I confront colleagues who just shotgun tests, and I look at notes from really individuals I respect profoundly as talented clinicians and think I wouldn't want to have to deal with all these results. Not only are they not necessary, but the amount of time and energy for myself, for my staff members, and then also my patients. I love when I can look a patient in the face and say, there's nothing more that we need to do. You can go home with your family. And so I've always felt really near and dear to my heart to provide the best value I can for patients as a family doctor. And it's been a real honor to be able to extend that into a systemic initiative in what my CEO, many of you may know, Dr. Malik Joshi, and myself have labeled as the Doing Wisely campaign. We felt that choosing wisely, as was mentioned earlier on this in this session, is winding down. And we wanted to make sure we had an opportunity for systems, not just individuals, to seek to do wisely, not just to choose it. So I'll share a little bit about our health system and where we are situated. We are a 327-bed hospital in rural Western Maryland. We're about an hour west of Baltimore, an hour west of Washington, D.C. We serve over 225,000 patients, and we actually have, as you can see, outreach across 4 states: Southern Pennsylvania, Eastern West Virginia, Northern Virginia, and then much of Maryland. And we really are kind of on an island. There's not a lot of other health systems or competition in this area. So if we deliver great healthcare, our patients get it. If we deliver bad healthcare, there's not a lot of other places for patients to go. So we really do have an onus of responsibility as a health system that actually has close to 90% of the patient volume within our immediate community.
And Aaron, I don't think we're seeing your slides. We are seeing you, and I admire how you tied your tie today. And
my slides aren't that exciting.
Okay.
How about now? Can you see this?
Yes, we are now. Yes, there's your cover slide.
Oh, perfect. All right. So here's
I think you were into slide 2 and 3 now.
Here's our blanket cover slide on Doing Wisely.
Yep.
And the map might just help with a visual of where we are at Meritus Health. Again, you can see we are about an hour west of DC.
Yep.
And Baltimore, but we really truly believe that our experience here at Meritus in Washington County, Maryland, is indicative of the greater rural, non-urban experience in the United States. And we feel like the patients that we care for, the community that we have, which is rural farming, is actually likely suggestive of what the 70 or 80% of the American experience includes. So we hope that this initiative lend some light for this group and certainly for others. We published this initiative last year in the New England Journal of Medicine Catalyst, and we hope that this sheds some light on what we believe is a system-wide, leadership-driven initiative to reduce unnecessary waste. And I know that a lot of the things that I'll be talking about over the minutes ahead are near and dear to this group. There's in terms of barriers to waste reduction, in terms of the reasons why to do it and different interventions. I know I'll be speaking on behalf of a lot of things that this group is commonplace in terms of your parlance and your daily work. But I think that what we've done here at Meritus is relatively unique. And the experience I want to share with you is one in which we approach this at a system level, coupled as a part of our strategic bold goals for our institution and for our organization and community. So briefly, I'll share a snapshot of the bold goals at Meritus Health. In 2020, just prior to the onset of the pandemic, we sat down and created 4 strategic aims. One was actually to lose 1 million pounds collectively as a community by 2030. And you can imagine there's no financial gain. In fact, we'll hopefully have less volume, less sick patients, less diabetes, stroke, and heart disease. But we believe that if our community can band together and lose 1 million pounds across our Chamber of Commerce, our school district, and others, I mean, it's the right thing to do. At Meritus, we have about 3,000 employees, and we are the largest employer. So we have led the way, and to date, we've lost over 80,000 collective pounds as a part of this initiative. We want to be the most efficient hospital in the state of Maryland. We want to be the best hospital that individuals want to come to. And again, as I'd mentioned, we want to create a world-class medical school. The The initiative that utilization, of course, falls under is harm. We, like many institutions, are seeking zero harm by 2030. And we know that unnecessary testing does harm immediately and has cascades of harm that follow. And so we have coupled our utilization initiative under our bold goal to reduce and get to zero harm. Now, I'll offer Dr. Joshi, who many of you may know, looks at this slide and he'll often joke, he'll say, you know what's different about Meritus's health strategic placemat that we have that makes us different than every other institution? It's the colors. And we know that a lot of hospitals like ours have very similar initiatives to reduce harm. And for ourselves, we've gone through strategic planning like other institutions where we sat down and charted out a 10-year goal. And for zero harm, that was to create 3-year isolated strategies that move towards 2030. We do have an annual operating plan that this distills down from, with strategies and metrics that are displayed on driver diagrams, AIM dashboards that are throughout the institution. But what I think that we did differently than other health systems, particularly with regard to utilization, is that we set a specific, measurable, and targeted aim. Using the science and methodology of quality improvement, who many of you are quite familiar with, we challenged our health system, not just one doctor, not just one clinic, to reduce 10,000 unnecessary tests in our first fiscal year. Now, this was through 2021 into 2022 when we initiated this originally. And since then, the initiative has expanded a little bit. But I did want to just walk through the steps of how we approach this at a systems level, because I'll share, as a family physician, I looked around and I saw that when it came to best practices, there wasn't necessarily much more than choosing wisely. And as you know, choosing wisely really inspires kind of a grassroots approach to utilization reduction. Let's identify one physician or one patient and create some background or rhetoric in which we hope they'll take the time to talk about what that means. And so you could argue about the effectiveness of that in terms of the initiatives and the recommendations. But what we wanted to do was to start at the systems-based level, from the CEO and senior leadership down, and say that this is a priority for our health system, that we're going to address it along our strategic dashboards across the health system, that we are going to set up targeted and supported groups, physician champions, and other leaders. And we're not going to just target one doctor. We're not going to just target one test, but rather we're going to target reduction of over 10,000 global tests. And we weren't sure if that was an ambitious goal or a low one. We thought that was at least a good place to start. And we felt that, of course, if we did this, we would reduce costs, but we thought that there would be an awful lot more felt throughout the health system as well. So the screen that you're visualizing now is actually a sample of what our dashboards look like across the health system. These are reviewed daily and weekly in system huddles at practice level, and they're visible and transparent on every floor of our hospital and throughout the health system. So there are literally hundreds of these that are visualized and demonstrate that at an organizational level, we want to approach this as more than just reducing the number of antibiotics that are prescribed or the number of opioids that are prescribed, or we want to reduce number of CT scans for syncope, but rather that we believe that across the board, we can tackle this in our ICU, we can tackle it in our emergency department, and it's not just the number of tests that discharge, that we really wanted to approach this at a systemic level, supported transparently by leadership. So we, of course, looked at what barriers exist, and I think that everyone in the room is familiar with likely every bullet point here. And what we found as we developed a task force initially, I had a lot of fun building this. I called it our waste reduction team. I like to use a lot of visualizations of garbage trucks, and I said that collectively we had the obligation to take out the trash in healthcare. And so for waste reduction, we had a good time building a larger team of about 30 individuals that met at the outset of our initiative and really said, what are our barriers and what is our why? And as each of you, I think, has probably found when it comes to reduction of utilization, every time you ask one person, they say, well, it's that person's responsibility. So if you ask a health administrator or a leader in the system, why is our utilization so high? They say, well, the doctors are ordering too much. And then if you ask the doctors, what are the problems? They say, oh, well, the patients are requesting too much. And then you ask the patients and they say, I don't know. And so you almost have this hot potato that bounces around. So what we realized relatively early is that this is a complex and multifactorial issue, that one test of change was not going to guess where we wanted to go. And we really needed to clarify very seriously what the goals and the why for this would be. And it was more than just cost. It was more than just dollar signs. This had to do with patient inconvenience. Of course, it had to do with harm. And particularly in light of the COVID pandemic, I really rang the bell for staff burden. And what I said over and over again to our physicians was, we know that staffing is tough. We know that we're struggling to find nurses, phlebotomists, technicians for imaging. Every time you order an ultrasound, every time you order a lab test, that may be one more patient that person needs to see. And that might be a couple of minutes that they could have otherwise spent having lunch and taking a breather, or it could have been a couple of minutes that they spent with a patient at the bedside comforting them. And so for our team members, I felt that this utilization went beyond the dollars and cents, but it just made sense for helping to offload staff burden. And we saw this when we talked to some of our technicians, particularly in the ED, that they felt that they had just a little bit more time and they weren't rushing around from room to room quite as adamantly. So as I shared, we developed an overarching garbage reduction team. I had a lot of fun with waste reduction and taking out the garbage. And from there, we created specific task forces that were composed of a physician champion who was accountable for tracking and leading our task force meetings. And then also, these were not monthly meetings with an agenda for an hour. These were specifically designed to be quick, rapid huddles. Some of them were standing and frequent. So these teams came together initially 2 or 3 times a week, sometimes for 5 or 10 minutes. And then as the year went on, those huddles spaced out a little bit less frequently. But the goal was not to have a structured meeting that would limit actual action between meetings, but rather to have real-time, dynamic, and frequent touch bases so that we could review data more frequently and watch how our tests of change and interventions were playing out. Each task force built out a driver diagram, and I'll share an example of one of our early driver diagrams for our lab task force. They had identified that the primary drivers for lab rested around education for those involved, responding to outliers and variability, and then harnessing technology. And you can see that each of these distilled into secondary drivers, some of our change ideas, and you could actually see this almost like a spider web, of course, transferring out beyond even the slide with the number of change ideas and interventions that we then played out for each of these drivers. We had the same for our imaging task force as well. And as soon as we started to walk through this, of course, you can imagine the response that we all hear is, well, show me the data. I'm the best. And when you actually speak with physicians about their level of care, surprisingly, every physician is above the 50th percentile. No one says, well, I guess I'm probably in the 10th or 20th percentile. And so it was really important for us to meaningfully share data that was reliable, that was frequent, and that had the ability to kind of dive and compare against peers. So for this project, we actually built an in-house data platform. We had been using it for some other things as well, but we created multiple utilization dashboards. And this was actually an in-house project that our IT team came up with called the Data Atlas. And truly anyone could access this. And it shared data at the provider level, at the floor level, and really provided the opportunity for us to look at transparent numbers at a daily basis, a weekly basis, a monthly basis. So we weren't waiting for the next month to come to say, okay, well, have you responded to some of the things we talked about? Our physician leaders, our champions, could address almost the next day to say, how did things look today? How did things look the following week after we had maybe a one-on-one for some variability? So I added this snapshot of what our data atlas looked like. This is our hospitalist scorecard, where you can see each hospitalist. We integrated HCC scoring for some element of at least proxy for risk adjustment. We felt it was important that if a physician came and said, my patients are absolutely sicker than everyone else's, we could point to their HCC score and say, either they aren't sicker than everyone else's, or you're not documenting the level of their medical complexity. And so we felt that that was a win-win to try to drive some of the documentation and increase our HCC complexity at the least. And at the most, it created at least some ability to compare providers in terms of the number of orders they were doing per day per encounter, in terms of HCC scoring, patient experience, and others. And then we were able to trend these, so you can see that we had data lines below. You could, with this platform, we could actually look at the level of the specific test that was ordered, whether that's an image or a lab, and you could look at day by day, floor by floor. So we could start to really parse out and identify some variation. We certainly did. We did the same thing in our emergency department, looking at CTs, X-rays, and others, as well as lab tests. And you can see, again, these were all not blinded. We shared these regularly in huddles. We were very visible and transparent. And again, anyone in the health system could theoretically access these if they wanted. So none of this was kept secret. And it was important for us to make sure that our providers knew that at a system level, we valued quality of care, and we wanted to drive improvement for patient outcomes. So I do want to share that over the course of the year, we implemented over 100 different initiatives. So this was not one or two things that worked, and got us to the finish line, but rather our task forces were constantly trying to identify different little areas to tinker around the edges and find improvement. I did want to share just 3 interventions and some of the results, just so you can have an idea. But I would offer, I don't think that there's a one-size-fits-all playbook for this. I think that if we could write the guide to reducing utilization and hand it to every hospital in the country, that would be great. But I think that what we found was that bringing together leaders, bringing together those that were involved in the day-to-day care of patients, helped to actually identify gaps in our specific context. So I'll give you one example of one of our early interventions. And this one was simple. We looked at triage for spine X-rays in our emergency room. So patients that came in, and what we found was that at the outset, over 5 patients per day were getting an X-ray that ultimately, when we looked at it clinically, was not necessary. And so we just eliminated the ability to triage directly to spine X-rays. And we found that we went from 166 X-rays that first month down to less than 2 per day 2 months later. So it was a simple intervention, but we saw a reduction of about 1,000 spine X-rays with just that very simple triage change. We, of course, rolled out scorecards to our intensive care team, and they actually de novo came up with the idea then that every evening at their huddle, when they were doing patient handoff for the night team, they would also look at all of the labs that were reflex ordered for the following day and just cancel any that they felt were unnecessary. And so it was you had the team-based approach. There was the daytime to nighttime physician handoff. They were already reviewing the patients anyways. They would run through the tests that were already ordered. And as you know, routine lab tests tend to be built up. And that simple handoff change led to over 3,300 less tests just in the next quarter. The last thing I'd offer just as an example was a review of the top 20 order sets. Again, these sound simple in retrospect, and you feel like every hospital in the country should be able to do this. We saw that we had a surprisingly high number of magnesium tests that were being ordered in our ICU. We removed it as a default from the order sets, and we saw a 47% reduction without change in outcomes or quality that was observable. And then we looked at heparin, which previously had been at the top of our anticoagulation order set in the EMR. And we found that patients that had heparin, of course, had a higher incidence of risk for HIT, but also required daily PTT testing without necessarily a benefit compared to other anticoagulants. So we just moved it to the bottom of the list, and we saw 46% reduction in that test. So by the end of the year, with, again, over 100 small tests of change like this, we saw over 32,000 fewer tests. And we estimated that of those that we felt fell into some criteria of routine testing, we felt that we reduced about 20%, just under. And across the system, as we reviewed it, we didn't find that there was any worse care, any worse outcomes, and everyone felt that the care that we were providing was more consistent with expectations and best practices. So from there, we have started transitioning this. Of course, you can imagine, as with any effort, sustainability is a first hurdle. Spread is the second. So we're seeking both. Our goal is to sustain what we've been doing, and we found that year over year, we've actually had an increase. This past year, we saw an overall increase compared to that initial period of about 45,000 tests. And then spread. So our goal is to spread more into the ambulatory setting. And of course, this group is familiar, and I've already heard some mention of things like low back testing, imaging, antibiotics, high-cost pharmaceuticals, preoperative testing, routine preventive care testing, and others. And so our next step is really to spread this. I'm really honored to have a chance to speak to this group. This is an initiative that was near and dear to my heart. And we placed a call to action in the New England Journal of Medicine Catalyst and said that we believe every healthcare system in the country has the responsibility to lead a systemic and targeted reduction of utilization for patient care. And so I hope this group would also help us to spread that nationally. And I can only imagine the improvement in cost, outcomes, and to be honest, staff burden. I think this would be a tremendous step forward if more health systems tried to do similar initiatives. So with that, I appreciate the time. I'm happy to answer any questions I appreciate everyone being here today to kind of talk through next steps.
Well, thanks, Aaron. This is great. And among other things, this is a really good case example of not just talking about reducing unnecessary testing in labs, but how you've operationalized it, how you interacted with your own staff, how you emphasize all the various kinds of ways that you could realize savings. Love the driver diagrams, love the in-house data atlas. Beth Bortz is up with a question. Beth?
Yes, thank you, Cliff. So I actually have two. For part one would be financial impact. Do you have a sense yet? And did you get any pushback from the CFO suite of folks about the financial impact of this? That would be the first piece.
We were surprised that the financial impact wasn't quite as apparent as we had anticipated. It was an area that we wanted to publish on. We felt when we ran the numbers that it impacted about 5,000 patients. But from a collection standpoint, in the grand scheme of things, the reduction, it was a little bit challenging to articulate. We wanted to share, for instance, the cost of the test saved, the cost of staff time to not run the test, and others. When I worked with our CFO to do that, he was really challenged to necessarily identify specific substantial savings. We were worried that it would look worse, that it wasn't as much as you would expect for the time and energy that we put into it. So our cost savings was less than $1 million.
Thanks. And then the second question I have that we've run into, do you have any critical groups of clinicians that you don't own that weren't interested in playing ball?
So I'll offer that we have a contracted intensive care group and a contracted hospitalist group. So they weren't necessarily directly employed. And we also had employed physicians that were operating in other areas as well. We chose not to tether any financial incentives to this. We felt it was the right thing to do. And so our impetus really in working with these groups was to say, you have an accountability to provide high quality care. And what you're demonstrating with outliers in your teams is that care is not as high as quality as it could be. So we tended to lean towards that as opposed to tethering financial incentives to it. I was really pleased that I think we took a very paced approach to this by inviting leaders from each of those groups to be a part of the discussion, asking their involvement in the task forces, and then placing some accountability as champions for them to lead their teams directly. So again, I think that balance of we as a system saw it as important. We placed a strategic effort around it from the CEO down, but it wasn't forceful that there was any one way with how it had to be approached. So we said, again, maybe the benefit of saying vaguely, we want to reduce utilization. You tell us what are the best practices that you think you could implement to help us get there. And so each of those, when we looked at the change ideas, those actually came de novo from the groups.
Beth, you are speaking as someone who certainly knows her way around the upsides and downsides of trying to make this happen. Were you surprised by Aaron's responses, or do you have any advice along the way? I know that you confronted every one of those issues yourself.
No, I was just, chuckling a little bit because our good friend, Dr. Fendrick, always gives me a hard time for picking what I think is a small number of things to tackle. And so, Aaron, when you said 10,000, I was messaging Mark like, look, I am chill compared to Aaron. So,
And he tripled it. Did I hear 32,000?
32,000, yes.
Good gosh. Well, before we move on, I have to make a personal observation, or I guess my experience. I'm from Maryland. I know Interstate 68 and I know Garrett County. And for those of you that don't know, when Aaron showed the map, that far western wedge of Maryland that kind of intersects with West Virginia and so forth, that is right in the middle of Appalachia. And you're moving into an area that has, it looks a heck of a lot different from the rest of Maryland. And it's an interesting combination. And I just wonder if you might have reflected on this, Aaron. You've got people that are in the lower quartile of the US economy there, a lot of kind of issues of transportation, rural access, health literacy, and people come in there seasonally who are some of the 1%ers. People come in there for ski holidays and boating and so forth. You're going to, with high expectations, you're going to have a really diverse patient population. Any thoughts about making it work there?
We do. I think it works on both ends. I would offer that, we found that if we could get patients home sooner, if we could order less outpatient follow-up tests, that's value for those that have transportation barriers, as everyone knows. I think that the top 1%, if we spoke to then more time at home, I think there was a desire for that as well. But I also think that we did not target specific demographics. We saw that this should be a global initiative for just based on disease state, based on best practices, order sets, and others. So we tried to spread this with equity.
Got it. Well, you're going to have some interesting equity issues out there, I can assure you.
We do.
But the need is great. And as was mentioned earlier, there are a lot of social determinants of health at work out there in that part of the county, that part of the state in Appalachia. So it's going to be about food, it's going to be about housing, it's going to be about environmental issues and transportation. So you have your work cut out for you, but it's plenty good work, it sounds, Aaron. I'll tell you that. Thank you. All right. I'm seeing, let's see. Yes. Mark Fendrick. Yeah, you can buy a lot of high value care with $1 million. No kidding. I hear you. Okay, Aaron, thank you so very much. What a great way to kind of get us moving on the main presentations here. And again, your tools and how you operationalize this stuff was really helpful and remarkable. Well, speaking of remarkable, it's time to move to Beth Bortz. Beth, we're looking forward to hearing about the progress on the no value care definition and your magic proposed list. Beth.
Great. And can everybody see my screen okay?
Yes, we can.
Oh, maybe not.
Well, we can.
I think that's Susan Lynn.
Oh, that's Susan's, yes.
All right. Susan, I'm going to go ahead and share mine, if that's okay.
Take over the sharing. There you are.
All right. Excellent. So, well, thank you all. I always love these meetings. It's like, a gathering of friends with shared interests here. So this is always energizing for me. Mark asked me if I would talk a little bit about the work that's being done around moving toward a no value list. And I really want to set the stage and share with you a little bit what came out of our Starfield Summit that we did. Many of you in this group were involved in that work. And then we'll go and talk a little bit about how that we got to the place of having a conversation around a no value list. So just as a reminder, we approached ARC now, I guess, about 2 years ago to talk to them about how do we come together and talk about promoting the reduction of low value care in the primary care space. One of the things I was most concerned about was, as our work was kind of exploding and different folks were getting engaged, how did we make sure that we didn't just have a proliferation of measures and made it really hard for primary care to engage? And so we thought it was the right time to have a convening to talk about how to improve measurement, and how to get people to take action. And so we partnered with the folks at the Center for Professionalism and Value in Healthcare, as well as the VBID Center at Michigan, and we were awarded the ARC grant. If you're not familiar with Starfield Summits, the American Board of Family Medicine has a history of these are kind of leading thinking in primary care. And so we asked them if we could use their vehicle of the Starfield Summit to advance this work. Because we initiated this during pandemic times, we used a different format. We had 4 virtual convenings instead of having kind of a 1-day or 1.5-day meeting. I will say, just as an aside, that format turned out to be excellent in terms of giving us time between sessions to survey folks, get more input, as well as, midway through, we did a little bit of a course correction. And we were able to do that because we had spaced out meetings as opposed to just a 1-day gathering. And you'll see there that we brought together folks, that were all in this space, from health services research to quality measure development, health plans, health systems, pharmacy, lab, health policy, and patient advocates all came together. So the purpose, as I shared, was to really advance and improve the measurement and value in primary care, looking at low value care reduction specifically. So I mentioned there were 4 sessions, and just to set the stage, in that first session, we did set the context. Why are we talking about identifying and measuring low care? What are some of the potential pitfalls and unintended consequences that might cause some resistance among primary care providers? What kind of measurement design would be authentic for low value care? Then we really went into, in session 2, exploring those options. What is a working set of criteria that we should use for identifying measures? What are the pros and cons for the existing sets of measures? Then we did a deeper dive into what are the key drivers, what are the key levers we have for reducing low value care, who should be engaged in the conversation, what is the appropriate scope of accountability. I'll share, that was a really interesting discussion. Where do we need to focus our research? And then we went to the 4th session, which is our developing an action agenda. And I'm going to share a little bit more about that. So you're going to get these slides afterward. I'm not going to dig in too deep into them, but there is some really interesting things in here. But when we set the context for that first session, why it's important, the unintended consequences, the pitfalls, we got a lot of really good information from the group, as you see there. Then we talked about criteria. Again, you can see, we were looking at choosing measures that are relevant, actionable, accurate, feasible. And then, the potential drivers. And this is really where I said midway through, we had to do a little bit of a course correction, because what we thought we were going to get from the group, to be honest, was, okay, we've looked at choosing wisely. We've looked at the U.S. Preventative Services Task Force. We've looked at international measures. Can we come up with a small subset of those that everyone is in agreement on? And instead, what we heard was, wow, there's a lot. I'm going to advance here for just a second and show you. I want to show you this picture. If you can see my Titanic image here, that was really the aha moment for me, because what we heard from folks was what you've been talking about, the choosing wisely measures, the U.S. Preventative Services Task Force measures. Those are important, but that's the tip of the iceberg. There's really so much else that is happening that is driving low value care. And you really need to understand all of that if you're going to make an impact. And so you'll see below the waterline there, if you will, things like referrals, relationships, sites of care, the 4 C's of primary care, looking at continuity and comprehensiveness. These are all things that when we talked to the frontline folks, they said was so impactful. And so that really caused us to think, well, if that's the case, how does that impact our coming up with a list? And what I'm going to tell you that came up with the impact was the accountability question. Because when we talked to frontline folks, they said, you know, you can't really hold us accountable, or it's very hard to hold us accountable with the information and the challenges. And I'm going to go back here and share with you. You'll just see slide after slide of challenges that were brought up. And then also the tools that were brought up. So here I'm giving you the drivers, you know, lack of time, lack of trust, complexity, time constraints, you know, not enough data, the culture of more is better, culture of care dominated by specialty, low research. I mean, it just went on and on. And so you could tell folks felt very uncomfortable with all these drivers, and is primary care the right focus point for talking about reducing low value care? And so as I jump forward here, that became the real concern. We definitely felt that there was a need for primary care to take some accountability despite the challenges. And so we really pushed back on the group to say, okay, we hear you. We hear that there are a lot of different drivers, but you need to step up. You need to take accountability. And so at that point, the conversation shifted toward a no value list for primary care. And so let me share a little bit, but I think we also have Beth Bowden-Saunders on today. And so I'm going to ask Beth actually if she'll unmute for a minute, because I think it would be helpful for her to share just a little bit with you about the development of this list, because the folks at Altarum had been working on this, and we were just in the right place at the right time to take the work that they had done and kind of bring it in front of this audience and test it further. So Beth, if it would be helpful, just to share, you know, briefly how the work that you were doing on the no value list.
Yeah, thanks, Beth. Well, first, I think we were very lucky that you all were working on this. Mark Fendrick and Peter Newman and myself were working on this idea of identifying no value services. And what we did was an environmental scan of Choosing Wisely, the U.S. Preventative Task Force Services, the cost effectiveness analysis registry at Tufts, where we looked at that Northwest quadrant of the registry, that space that not a lot of people are in, where it's not a benefit in cost, it's not a benefit in health, it is actually more harmful than good in that quadrant of area of CEA. We also looked at the literature and the research that was out there already. The Low Value Care Task Force, of course, lists and VBID-X, and the list and services that were in the Med Insight Health Waste calculator. And so we compiled all of this environmental scan and started with about 372 services that we looked at, and then scored them for whether or not they could potentially be in this bucket of no value care. And at that point, then we really had this list of about 72 or so services that we felt that could be measured, that could be potentially in the no value bucket, and that we wanted to start to vet. And then we were very fortunate to have Beth and the Starfield Summit group be available to us and participate with us. So Beth, I'll turn it back over to you to take it from there.
Great, thank you, Beth. And so Cliff, I want you to know that these meetings, you see, we all do pay attention to each other, and then we follow up, and we work together on advancing things. So I'm thankful to the Altarum folks, and we then took that initial list. We took the ones that we thought applied to primary care, and we started with a survey. So the advisory committee for the Starfield Summit, that 50-person group, they all got the list. And we asked them which ones they felt comfortable would be ready for inclusion on a consensus list. Then we brought that information back to the big group. We had a discussion about the list. At the conclusion of session 4, we weren't entirely comfortable that everyone was fully on board in a consensus place. And so we then had some of the clinician members look at those recommendations one more time to see if there was any, refined phrasing that might help make relevant for primary care settings. They removed 4 of the 35 that they really felt weren't relevant for primary care. So now we're down to a list of 31, and we use that survey functionality again. And so we sent it out to the group and we asked them to identify any specific concerns that they would have around those recommendations that are related to implementation. And so I want you to see in the next slide here, you'll start to see that on the far left, you see the start of the list of the recommendations. And then we gave them categories of potential concerns that they might have. Should we not put them on because there's patient resistance, or it would be very difficult to implement in daily practice, or is the data and the measurement not right yet? Do we have conflicting payment incentives? Is there a malpractice risk? Do we think there's going to be policymaker resistance or other factors? We really wanted to drill down into where was hesitation for things to be on the no value list. And then you see in the kind of the second column from the left, we listed these in terms of the cumulative number of concerns identified. So that very first one there, what that suggests is of all the members of the committee that completed the survey, only one concern was noted with that measure, and that from all the different buckets of concerns. And so you'll see we go down in order. And as we go, the number of concerns increases some. But again, remember, this is 50 people and there's multiple categories of concerns. So we went through, all the way down to the 22 concerns. And so what are at the end of the Starfield Summit, where are we? So, we believe that the next steps, this was a good group effort, but if we're really going to advance the no value list, we want to complete the vetting, do one more round of using the medical literature and stakeholder surveys to really make sure that this is a tight list and that people are really comfortable with saying there is no value to these services. Then we want to work with our friends at Milliman MedInsight. They've already been, I've already run the list by them. They're already making sure that the health waste calculator could look at these specific measures, and we could run some initial data reports. We can run it in Virginia. We'd actually like to run it with several other states to get a sense of the magnitude. Then we want to evaluate the cost savings that there could be from doing a national demonstration project and create a scaling strategy. After we, do all that work, then it's time to take it beyond primary care, right? We started with primary care because that's kind of our comfort, our sweet spot. But we already started with identifying 5 other specialties as a next phase that should add specialty specific measures to a new value list. And then, we've got to figure out the sustainability strategy for this. Right now, we're still hoping that I've shared, I think, with this group before, that the Federal No Surprises Act, when it was passed, it designated that there would be funding for up to 25 states to do either the creation of an APCD or to do a quality improvement project. And so we're thinking this could be the quality improvement project for all those state APCDs. So that was kind of where we ended with the no value list, but there was one other piece that I just want to make sure we share that came out of the Starfield Summit. And as all those sessions were going by, we were keeping track of what is the research and development agenda that we are seeing come out of this meeting for low value care? And so you will see that the agenda falls into 3 buckets: ways to improve low value care measure development, understanding low value care influencers, and making low value care reduction actionable. And so again, I'm not going to read them to you. They're here in the slides, but we have specific research questions under all 3 of these headers that we believe it's valuable for ARC to see that significantly more research is needed in each of these areas as we move forward. So with that, Cliff, let me stop sharing. Mark wanted me to make sure I left plenty of time for people to ask questions. So I'll turn it over to you.
Well, thank you, Beth Bortz and Beth Bonansala. Very helpful. I'm just wondering, right off the top, Beth, elevator speech, this Starfield set of events accomplished what that extends beyond what Choosing Wisely was able to do? What does this add to our body of knowledge, or how to make these things work?
A couple of thoughts I have on that, and then I'd actually open it up there's quite a few folks here that were part of the convening. What I would say is that one of the limitations at times of the Choosing Wisely work is that you were asking essentially a membership organization to require their members to stop doing something. And that's a really hard and sometimes awkward position to put that members association. So we wanted to have a little bit of a broader conversation where we are not a professional association representing any of the folks around the table, so that nothing would be kept off the table for discussion. But we also include, you'll see there's just many different stakeholders that were part of that table: employers, pharmaceutical lab, health systems, health plans, all part of the discussion.
So
in addition to clinicians.
So the span of stakeholders engaged here.
Definitely.
Okay.
Definitely.
In the list of 31 now, remind us again, what goes next with the 31?
So the next steps will be to do another round of vetting, if you will.
Another round. Okay.
Just making sure that everyone is comfortable. And then, trying to put some numbers to that. What would be the impact? If we did a national demonstration project around a no value list, and Cliff, I'll tell you, this is the debate. You've been around long enough to hear Mark and I have this debate all the time, right? Like, I want the list to be as big as possible. Mark wants the list to be as actionable as possible. This was kind of that compromise of, it's no value. You've taken out the clinical nuance challenge of what we've been talking about. It should be really straightforward, and let's make it be a national campaign.
I hear you. Well, Chernu's got something to put to you. Mike, what do you got?
Thanks, Beth, and thanks, Cliff. So that's terrific. The question I have relates to this exact point, which is, do you think that when you pick a list and get people to focus on value and the list is precise, that you limit their attention to the things on that list, or that by getting them to focus on value in general, you might get them to expand what they're doing, even if there are services that aren't explicitly on the list?
That's a great question, Mike. I would say I'm hoping for a quick win. I'm hoping that with a no value list, and because there's, none of the clinical nuance stuff for people to get caught up on, they can take action, they can see results, and then we've engaged them in the dialogue to go further on the, more clinically nuanced items.
So Mike Chernu, does that work for you? Is that going to kind of pan out okay?
The reason why you convene groups like this is so you can get the real answer and not ask me. In looking at my screen, I don't know, my screen doesn't have everybody here, but I think if you were to array the people on the screen, I'd be in the bottom decile in understanding how to change clinical medicine. But my reaction in general is, if you're going to get very close to clinicians and do what Beth is doing, you have to get quickly over the debate about whether something is low value, no value, or whatever it is. And that requires a level of precision just so you can have the conversation. But eventually, I think the system more broadly has to be held accountable for a much wider set of low value care / no value care than we're measuring this or in fact and everything else. That's why the spillover part of it, the attention on it, the thinking in whether things are needed, like was just discussed about test ordering and those processes. I actually think there can be a lot of spillover from that way of thinking if you can just get people engaged, and you probably do need to be very precise to at least get people on board with thinking about value as opposed to just how they've always done things.
Aha. Beth, could you put your final slide back up there while we're speaking about this?
Sure. Hold on.
Thank
just
you.
A second. It'll take
Yeah.
me. I closed it out, Cliff. Hold on. Just give
No,
me
I
a
know you're being hyper efficient. I know that.
So hold on one second. I think I can.
Okay, if you can put that back up.
All right.
And then I'm wondering, and I'm not the person to answer this question, the issue arose in the Beth's presentation about starting with primary care and then moving to other specialty areas, and there seemed to have been pushback on primary care. Doesn't it make sense to start with primary care? I mean, once you send patients who have not quite been diagnosed yet down the wrong pathway, you can generate a lot of low value care. I would think starting with primary care is the right place to start, but am I missing the point there? And I'm hoping that someone will comment on that. Start with primary care or go to the specialties. Gwen Darian's got her hand up. Gwen, you go.
Okay, I was not at all going to comment on that.
Go ahead. I know you had a comment.
But I was going to say, I put it in the chat. It was the Starfield Summit format was an incredibly productive and fulfilling process. And I think one of the things that I so much appreciated about it was it really allowed everybody to participate, everybody's voices to be heard to a common end. And I think a lot of the methodology that we use to convene groups doesn't always do that. And I was really pleased. I mean, I thought that what the group came up with has the potential for a great impact. And it is a format I think we should continue to use. Of course, I think primary care is a place to start. I would also add, I think the specialty care is quite important, and it should align with some of the where we're looking at low value care. So it was a good place to start with primary care because that's the center of everything we experience, but then we have the unfortunate offshoots into specialty care. I really appreciated being part of it, and I thought it was a great way of bringing in many different voices. I know Beth is always attentive to multiple voices in the room, but sometimes the form of convenings doesn't support the intention of the people who are the conveners.
When did you take it as a highly credible process? In other words, you were part of it, so people walked away, they didn't think it was a sham or anything was kind of manipulated. It had credibility.
Absolutely. And I think it had credibility. It was a thoughtful and interesting process. I also wanted to highlight what Beth said in the beginning of her presentation, that it's also highly adaptable. And so often when you're using processes like this, you get stuck in the process. The process drives the experience of the way that you come together. But this was really adaptable, and Beth was able to adapt based on, and everybody else was able to adapt based on the findings from the prior get together, or I don't know. So yes, I think that was also made it very credible that we weren't just checking boxes.
So it's kind of a Bayesian process there, just as you go.
It was.
I see Mark Fendrick's hand is up. Thank you, Glenn. Mark.
Beth, thanks so much. Welcome to the persona non grata club. So, as you know, many of the organizations that Cliff and Beth and we work with has made development and expansion and investment in primary care a top national policy priority. And here we are continuing to bang the drum that a substantial effort around no value care starts with primary care. And I don't balance these things as well as you do, Beth. How do you basically allow to keep these organizations happy who want to move primary care forward as kind of a blunt instrument while we're picking away at the fact that they have significant advancements to do if they were to pay more attention to no value care?
So, Mark, I think when you ask, and it ties into Cliff's question about, is primary care the right place to start? And full disclosure, I also staff Virginia's task force on primary care. So like for me, this was like the sweet spot of the two groups and talking through, but I think historically, this came out of the American Board of Internal Medicine. Let's remember choosing wisely. I will say that the primary care specialties, I'll go ahead and say, might have taken the exercise most seriously, in that, they didn't just come up with like 5. I think like family medicine started with a list of 15, when they responded to the challenge. So I think there has always been an interest in primary care. I think primary care is closest frequently to the patients who have no other means of paying for care. They see a lot of those folks. They know the challenges. So there is a real commitment to addressing low value care, but they also, I would say, feel the least capable. They're the quick to respond that it's a lot of it they have to do for specialists, or they're required to do this to get their patients the care that they need. And so we really had to break down that conversation for them about, we know you very much want to do this, but we also know you feel that you don't have the right tools in place. How can we give you something that's actionable? And so that's really what we got. I think that was the no value. I think they felt very concerned that they don't have the tools yet to do work that's very clinically nuanced. And so starting with no value was a comfortable place for them.
Right. Potentially less controversial. I think it was effective when you flashed those slides about the listing of concerns and you sort of added them up. I mean, they're not necessarily additive, but the point is that you did acknowledge by showing these slides, you did acknowledge, yeah, we know that there are concerns. Here they are. We know there are a bunch of them. We're not saying that these no value services are without concerns. We're accounting for them, but we're still compiling this list. I think that provides some kind of intuitive transparency to users and so forth. So thank you for that.
Absolutely.
Well, Beth, thank you very much for this presentation. And it's great to see this taking on an additional life. Learned a lot about the methodology, learned a lot about transparency here and engaging stakeholders. And it'll be interesting to see, to the extent this does move beyond primary care, where you get more or less in the way of resistance from those heavily armored and strong lobbied medical specialties. Be interested in watching that occur. So thanks a lot. Okay, thank you. And we're now going to move to hear a little bit about the HCCI National Low Value Care Report. It really is nice kind of product derived from a lot of work. And Aditi Sen is up next. And I think we're going to have screen sharing started soon. There it is. And Aditi, are you there?
I am here.
Welcome. Yes.
Yeah, the slides look good.
They do indeed. Well, the first one does, sure enough.
First one,
yes.
at least.
Yeah.
That's the first start, so that's good.
We're with you for about 20 plus 10 here. Mm-hmm.
Perfect. Okay, great. Well, thank you so much for having me. And I am going to come back and thank Mark and Mike again later, but really appreciate both their guidance throughout our work on this report and the invitation to come and present to you all. And I'm really looking forward to hearing your feedback and also hearing, and I already started to hear it during the previous presentation, but sort of where we might bring more research and data and analysis to this sort of topic of low value care and in terms of identifying it, making the data more actionable, and all of the kind of points that were made in the previous presentation. So let me see if I can move my slides. So I'm going to talk a little bit about HCCI, but I'm the Director of Research and Policy at the Healthcare Cost Institute. We are a small 12-person nonprofit, nonpartisan think tank in Washington, D.C. And I'll tell you a little bit more about our data. We house a pretty robust set of commercial claims data, and we also have Medicare and Medicaid claims data, which we use both for internal research, and we license out our commercial claims data for academic and other policy researchers to use for their research. But this report on low value care really fits into kind of our internal policy-driven research agenda. And the sort of motivation for this report is that since more people in the US get insurance through their employer than any other source, these strategies to reduce low value care should be informed by data on the provision of these services among this population in particular. And so that's what we're trying to contribute. And so what we're going to do is examine the use of and spending on low value care in 2019. So we're looking pre-pandemic on purpose, using our data set of healthcare claims, which includes claims data from over 1/3 of individuals who have employer-sponsored insurance, which we refer to as ESI. And to identify low value care, we're going to use the Milliman Health Waste Calculator, which I heard has already been talked about a bit today. And so, as people on this call know, that this tool measures provision of and spending on a whole range of services that are determined to be low value based on clinical evidence and guidelines. And just to give you a little bit of a preview, our kind of initial sort of base findings are that about 18% of people with ESI in our data received at least one of the low value services that are identified by the Health Waste Calculator. We can talk about it more. Very few people received more than one in our data in a particular year, but it is quite widespread, right? 20% almost. And what I'm going to really kind of focus on, what our report really focuses on, and what I'm going to talk more about through this presentation, is that we find that the use of and the spending on this set of low value services is highly concentrated. So just about 7 of the 58 services that are included in the waste calculator were responsible for almost 70% of the low value service use and spending in our data. And so, when we get to the end, I'll talk a little bit, but would love to hear others' thoughts on, whether this kind of finding about the concentration really makes these sort of data actionable, right? There's just a small set of measures, and sort of addressing the spending on and use of those measures could make a big difference in this population, at least. And that's what our data suggests. So I think
just before you move on, so I want to capture that 7 account for 70%, right?
Right.
Okay, it's a good sort of capture kernel there. Thank you.
Yeah, no problem. I'm gonna get into it, but yeah, that's really the kind of key takeaway. Yeah. So I think everybody here is likely familiar with the Milliman Waste Calculator. As I said, it's a claims-based method algorithm to capture a set of services that are determined to be low value based on clinical evidence and guidelines. I listed a few, just 4 of the services, but they're quite wide ranging. We'll kind of see more as I go through and show you our results. But it includes things like vitamin D testing, PSA testing, preoperative baseline labs for low risk surgeries, imaging for lower back pain within the first 6 weeks. So a whole set of metrics that should be very familiar to this group. It does take into account patients' clinical and demographic characteristics when determining whether a service was what the algorithm will say is low value or likely low value. So there's sort of a look back period, and they look and they see it pulls from the claims data whether the patient should be, or the service should really be included in the kind of denominator and considered to be low value. And of course, that algorithm is different for each of the different services in terms of what they're looking for, the claims. And it counts as wasteful spending dollars associated with the trigger event, so the specific low value service, as well as related services. So for example, that could be an office visit that led to a low value service. And it has sort of a whole algorithm for determining those related services. One thing I wanted to note is that we don't capture cascades of care, which are, you know, obviously a big concern with these low value services, is that you have a low value service and that leads to this whole cascade of low value care and additional spending. But our analysis doesn't capture that. And also it's not, you know, all low value services, right? So it's likely an underestimate of the true low value spending and use. Okay, so let me just jump right in and tell you kind of what we found. So to sort of start to look at this concentration and kind of what are the services driving low value care spending and use in this employer sponsored insurance population, we wanted to see which services accounted for most low value care. And so we identified the 10 most commonly provided low value services. That's what you see here. And then on the next slide, we'll talk about the 10 low value services with the highest associated spending in our data. But here what you can see are the 10 services with the highest use in 2019 in our data. So again, the ESI population. And you can see that the most commonly used low value service as captured by the waste calculator in our data in 2019 was inappropriate opioid prescribing for non-cancer chronic pain. And that represented almost a quarter, about 23% of all low value care. And then you can see it kind of goes from there. So other high volume, low value services were cardiac screens for asymptomatic patients, antibiotics for upper respiratory and ear infections, vitamin D testing, PSA testing, so routine general health checks for asymptomatic patients, these preoperative baseline lab studies, and then sort of on down from there. I do want to make a note that the way that the Milliman waste calculator captures PSA tests is all PSA tests, regardless of age. And so I know that since the USPS TF ratings have changed a little bit to include men of 70 years of age and older. So that's not reflected here. That's not reflected in the waste calculator, the version that we used. So then we look at services in terms of highest spending low value services. And what you can see at the top there is that in addition to making up about 16% of low value service use, which we saw on the previous slide, cardiac screens for asymptomatic patients accounted for about 23% of all spending on low value services in our data. So it was the low value service associated with the sort of biggest chunk of spending among these 58 measures in our data in 2019. And you can see that another 20% of low value service spending was on baseline lab tests for patients prior to low risk surgeries. And below that is vitamin D testing, there's some imaging on this list, and PSA tests are also on this sort of high spending list. So basically what we took away from this are a few points. So one is that the 10 most frequently used services make up more than 90% of all low value service use. So that's the 10 that we just saw a couple slides ago. The 10 services with the highest spending, that's what we just saw on the previous slide, made up more than 75% of all spending on low value services. And then we isolate these 7 measures that are on both lists. So they're both frequently provided and they're costly. And our goal here is really to identify these services because that can help payers, providers, and policymakers really target efforts to reduce low value care and associated costs. So here are all of the measures you just saw, but showing the kind of 7 in the overlapping circles. Those are the 7 that we're talking about. So together, these 7 services represented 70% of low value care and 68% of low value care of spending on low value care. So reducing the provision of these services, we think may be an efficient way to mitigate the impacts of low value care in this population. So of these services, you can see there are 3. There's vitamin D testing, prostate cancer screening, and cardiac screens for asymptomatic patients. These are all considered low-value screening tests. And just these 3 made up 34% of low-value use and 35% of low-value care spending in 2019 in our data. Then there are these 2 preoperative evaluation measures, lab tests and imaging, both prior to low-risk surgery for patients who are otherwise healthy. These made up about 7% of use and 26% of spending. And then you can see there are these 2 other ones. There's this inappropriate opioid prescribing. That was the most commonly used service we saw. And then finally, these routine general health checks made up about 4% of use and 6% of low value spending. So just to orient you to the rest, you can see that on the left side, these services with high use, but not high spending, and the blue circle, those affected the greatest number of patients, but they're relatively low cost on average. You can see that the average price per service is $27 of this set. So they're relatively low cost services. And then in the orange, you have measures with high spending, but not as high use. You can see these are really expensive on a per service basis, but they're less commonly provided. And so the sort of middle set, the overlapping set, the average price per service is still pretty high. It's more than $300 per service. So they're relatively expensive, and therefore reducing their provision could curb a considerable amount of low value care provision, as well as the amount spent these services. So that's really our main takeaway, that addressing a relatively small set of services could substantially reduce low value care among ESI enrollees. As we know, that despite efforts to identify and reduce use of these services at many different levels, people still receive them. Obviously, we see that in our data, but our data also suggests that focusing on a small number of measures could reduce low value care substantially. And these are in particular these 3 screening tests, the 2 preoperative tests, routine general health checks, and inappropriate opioid prescribing, which is the most common. So in terms of our work on this topic, we are releasing a report on this report that I've summarized, basically. This report we're going to be releasing next Tuesday on the 25th. And then we have a couple of other projects planned focused on low value services in this ESI population. One which we are excited about is using some of the no value care work that Beth just talked about, and other works are by this group, hopefully, to assess no value care in our ESI population and in Medicare, and also thinking more and sort of doing more analysis about provider practices regarding low value care. For instance, something that we can see in our data is whether provision of this care is really concentrated among certain types of providers, and sort of how we can use that to help us think about some of the local variation in this care that was also mentioned previously. So let me just take a moment to give some acknowledgements. Obviously our HCCI staff and leadership put in a lot of work. It's a lot of computing work and coding and kind of weedy technical work to implement the minimum waste calculator and sort of assess and analyze all of its output. So I thank my colleagues at HCCI, Mark and Mike, for all of their guidance on this project, really thoughtful comments and on the report, but also all through, and just very much appreciate your engagement and enthusiasm in our work on this topic. To Q and Kathy for their feedback on the report, and then Jansen, who supported our use of the Milliman waste calculator. We really appreciate that. And the Milliman staff and analysts who were very helpful as we were implementing the calculator. So thank you. Let me stop sharing. Yes.
Well, Aditi, actually, I'd ask, can you put the slide that shows the last Venn diagram back up there, please, if you don't mind? And thank you very much for very clear presentation. And it just seems at this point, given the various iterations of effort to identify low and no value care services, that who could be against canning these 7? They're derived from a set of 10 most frequent, overlapping with 10 most highest spending. You'll land on these 7. There's evidence to support, I believe, all 7 of these. What's to stop payers from saying, we're ready to go with these across the board? Just kind of that shouldn't be such a provocative question. Mike Chernow is up, has his hand up first. Mike?
Thanks, and Aditi, thanks. Obviously, I've known about this activity for a while, so I'm going to make a comment or two and then maybe see if others react. So first, when Mark and I started this movement or desire of ours to find ways to reduce the use of low-value care, the biggest critique was it can't be measured, it can't be measured. So let me first say, and I think this is important, it can be measured, and it can be measured on a large scale in claims data. And you've shown that that's true. I think that's important. For those of you that care, and you might not, I might add, relative to the amount of money that's being identified here, I understand it's not going to solve all of our cost problems, but the actual cost of measuring it is quite cheap in the grand scheme of things. So to those people that say it can't be measured, I just think that's basically wrong. The second thing that I think is important to acknowledge is there is an issue about how precise you have to be in the measurement. And for doing some of the very specific on-the-ground clinical activities like we heard about earlier today, those require a certain level of precision. But I do believe for a number of interventions, and I'll mention one in a moment, you don't need quite that same amount of precision, because while you will be measuring some things as low value that might not be, per Beth's tip of the iceberg chart, you're going to be missing a lot of things that are low value. So I think you have to understand that for a lot of interventions, we can work off of reasonable averages. And I think the core thing is in some ways to titrate the intervention to the precision of measurement. So I had a little bit of a back and forth with Bill Kramer, who may jump in, but I'll tell you what I would love to see the world do, and then I'm going to watch the hands either go. I wish there was a little running away emoji. I could see the hands that go up, and I could see the people that are actually running away. They're not just not asking a question, they're actively running away. But the intervention,
Mike. Lay it on us, Mike. What is it?
The intervention that I would love to see is employers holding carriers accountable financially for the amount of low-value care delivered. And because the measurement's not precise, you don't have to pay nothing for potential low-value care. You could pay 95 cents on the dollar, for example, for measured low-value care. You could pay 90 cents on the dollar, some version of that. And while it's true, you'll be getting that wrong sometimes, you're still, as an employer, paying a ton for low value care. And I don't think there's many other inputs employers would buy if they knew the input they were buying was defective. So I'd like to see more activity on the employer space to hold the carriers accountable and not allow the carriers to say that's not our responsibility. And I'm not sure what carriers are here, so I'm looking for more hands, but I guess Silas is next, and maybe Aditi could react to that, or maybe Bill could react to that.
Well, first, Aditi, do you have a quick reaction to that yourself?
Yeah, I mean, with that, I think I was going to say that too, when you were talking about sort of, could there be pushback for these 7 that I think, where we look at employer-sponsored insurance enrollees. So I would agree that I think this should be informative and actionable for employers, and insurers also. And I think because there's some real dollars at stake when you look at both the high use and high spend services, it's sort of a useful target.
Yeah, the employers are certainly much more discerning in other aspects of their business, that's for sure.
Yeah.
Silas, you're up next.
Yeah, thanks everyone. Thanks for the presentation. And I really like the way this came together. We've done individual institution level, low value care. We've done networks and states, and now we have a big commercial view. And so I really like the way this, the array of measurement of low value care is expanding. And I like the question about, Michael, your point about, the relationship with the employers. I'm also wondering about, did you measure the amount that came from the patient here? The patient part, was that able to be estimated for these different things?
Yeah, we did. Thank you. That's a great question. We did. And it's in the report. So we found that, I think that the number, we have the exact number. I mean, we have the sort of total cost number, and then of that cost, patients paid about 20%. So it's once you get up to sort of total levels of spending, it can be quite it can be quite a lot for patients. And of course, some of these services, especially the services that are associated with high spending, are quite high priced when you look at sort of total spending per service. And if patients are paying about 20% or so, those can be really expensive.
Yeah,
sure. I wonder if that's part of the messaging or strategy or,
Yeah.
or how you would use that information.
Yeah.
Great point, Silas. Thank you for that. Always, patients may want to know when those out-of-pocket costs start adding up. They might want to know that, hey, this thing might not provide any useful information. Thank you for that. Denise, you're up next.
Thanks, Cliff. Yeah, it's thank you, Aditi, for this. Yeah, it's great work, and really aligns with what we're doing at the Washington Health Alliance. And as I said earlier, inappropriate opioid prescription was one of the areas of focus for us, along with advanced imaging, inappropriate, right, in the first six weeks of low back pain. We actually added in visits to the ED and unnecessary surgeries. So and it can be really challenging to get everyone around the table to look at that, and push back from health plans. Like, we're not worried about opioids. We've already seen that trend drop. That's not really our concern, which was also interesting. But in terms of purchasers holding health plans accountable, we heard a lot of health plans say, well, we have value-based contracts in place, you're not utilizing them. So push back from them. Purchasers didn't back off. They continue to have discussions around that. But there was also talk about when you're in a value-based contract, does that money actually get down to the individual provider, and is it really changing their behavior? So anyway, just thought I'd share those.
That's a point well taken. They're already in some of those contracts but not being used. You've got a point there. Let's go next to Bill Kramer, also at PBGH. Bill, what do you got?
Thanks. Appreciate Mike challenging the employers on this. I know Mark has also done tried to engage employers on this. This is a very important issue, and I think the data that Dee presented, as well as the information that Beth presented on no value care, was really tremendous work, and I think it is worth sharing with our members and other employers. As you know, this is a long-standing issue. Our members are aware of this. They're very concerned about this, but it's challenging for them to make the changes necessary to the benefit design, or to put pressure on health plans, particularly when things like this get into physician prescribing patterns, raises potential problems with the physician-patient interaction, requires a lot of education for employees and their families. So it's not a simple flip the switch kind of thing. And you all know this, but I just want to remind folks that it's not the problem is not awareness of the issue or concern about the problem. The issue is what to do about it and how to make it work effectively and to minimize blowback from employees on changes that are well communicated. But I think Randa works more closely with our members directly on these kinds of issues, and so she may have some more detailed comments to offer.
Well, let's jump over to Randa then first. Randa, can you follow directly on Bill's comments, please?
Yeah, I think Bill did a great job of articulating how our members feel. I mean, one of the things that we have done around accountability for low value care is we have a benefit called the Health Value Index. And our members authorize us to collect data on quality, low value care, equity. And so we collect that on behalf of our members in an aggregated form. And so we have a couple of these measures in the 7 measures that you have that we get data on from the different carriers, and then we aggregate it. And then we do a collective impact discussion with each of the plans. So United, Cigna, Aetna, Anthem. And then we have some regional, smaller plans. But when you have, say, 10 members telling a health plan that you should, that we're not seeing progress around a low value care measure or equity, it really can be a really powerful way to really send a message to the carriers that this is something that's really important to employers.
And is there one single thing that you think is the right button to push or lever to pull to bring this about? I know there are a lot of concerns and opposition and barriers and so forth, but among those employers, what do you think would be the most compelling?
Yeah, I mean, what is the most compelling of the 7? I mean, what's most compelling is, I mean, really, at least for the carriers, that is around collective impact. If they hear enough noise from their clients, then they usually will act. They usually say that employers are not aligned in their thinking and their requests. So I think from our perspective, we're trying to send, a collective message from our members on what's important to members. I think from why this is important to them is, I mean, we all know this, cost is really significant for them, and sometimes low value care can do harm. Employers are really focused on upstream health and whole person health and well-being. So it really just supports their entire strategy to really push back on this.
And getting alignment towards that end. Thank you. Briefly, Mark, and then back to Denise ever so quickly. Mark?
Yeah, I just want to say, to take us in the break first, Aditi, thank you so much. And these comments are very useful. Low value care, I'm now changing outside of this task force. I'm going to strictly call it harm reduction moving forward, Rhonda, for the points made earlier. It's been really hard. And there have been a lot of us who have been intimately involved with the Choosing Wisely initiative. And just because the evidence has shown that most of the things on the Choosing Wisely list have not declined substantially in their use, is one of the driving forces for outside organizations kind of to shut this thing down. So when I think about carrying the torch, and I wink at Beth when I talk about, we've made significant headway, Cliff, in removing vitamin D testing. Big whoop, because Chernu and Beth would say that you barely see that on the balance sheet. So the ultimate trade-off for me here is that there's one group of stakeholders that push us for precision, because we don't want to take away things. We don't want to stop people from getting services that in some cases actually benefit them. The more precise we've gotten, Cliff, over the 7 years you've been helping us, smaller the aggregate number of the low value care use that we actually can get rid of gets smaller as opposed to larger, which is what Mike Chernu and everyone else he hangs with wants. If we came out with a number of 20% as opposed to 3%, Cliff, I think the response to this would be much, much different. And the final point is, as Aditi and Mike and I and the fabulous HCCI team work together, remember that we're talking about a certain number of measures within what we include in the health waste calculator, which is a tiny proportion of no and low value care. So this is, we've used iceberg for another reason. This is the tip of the iceberg. I don't want to think that we're going to lose this momentum given the progress we're seeing in the Commonwealth of Virginia and Washington and now many other states moving forward. So I will continue my cautious optimism in an in a Tigger way, while some people might suggest that EOR is going to win the day.
We think not. Thank you, Mark. Less than 1 minute, Denise, less than 1 minute, Beth, quickly.
Okay, I'll talk fast. So just jumping back to holding carriers accountable, there just is an irony in this system in that as it pertains to MSK, there are a lot of digital solutions out there that came about because of employers looking for solutions that they weren't getting. Many of those carriers now contract with those digital solutions and have found a way, right, to sell those to the employers. So it's become another financial stream for them. And it's all become a workaround for the system. So as we talk about holding the carriers accountable, they're contracting with these other services instead of creating different forms of payment for providers to help move the system. So just something for us to consider.
Good point. Thank you. And I appreciate it as well. Thank you, Denise. Carol Huffman's point about the EMR alerts and so forth, but noting that we need a better participatory method for creating these products. Point well taken. And thank you. I mean, that kind of reflects on Beth Bortz's experience with the Starfield effort as well. Ever so quickly, Warren Tays, I know you joined us a little bit ago. Do you want to say a quick hello? Warren Tays.
Hello, this is Warren. Thanks so much. I appreciate it.
Well, thank you, Warren. Good. We hope that you'll be further involved.
Yes.
Aditi, thank you for presenting this. This is some pretty clear stuff. We really appreciate the work you and your team did on compiling the data and the analytics, the capture of 10, overlapping with 10, yielding 7, that account for 70%. That's a very powerful message to take forward in any case. So thank you very much. Great, well presented. We're going to take our break until 15 minutes after the hour. When we come back, David Kim will be queued up to talk about low value care cascades. In the case of prostate cancer screening, I think it's very timely. One of the points that Aditi made was that it's hard to get your arms around cascades. And so we're going to be very interested in hearing what David's got to say. So we'll see everybody at 15 minutes after the hour. Great first half. See you then.
Thank you so much. Thanks for having me.
Thank you, Aditi.
Appreciate the feedback.
We're going to look next at a particular instance of testing that's low value prostate cancer screening, which has been raised before, but David's going to provide a kind of very helpful angle on that, including some lessons learned here. I think it builds very nicely on the work we've seen thus far today, including the aspect of with the information that Aaron George presented with regard to a healthcare system, what Beth talked about with regard to a process that is highly collaborative, and it was nicely transparent on things like concerns. Aditi shared the information about the 10 most frequent, the 10 most highest spending, and the 7 that fall in the middle of the Venn diagram. They account for 70%. I think you saw prostate cancer screening pop up in a few places already. So let's turn it over to David Kim now with regard to lessons learned from low value prostate cancer screening. David, what new stuff do you have to share with us?
All right. Thank you. Thank you so much for having me to this incredible meeting. And then today I'm going to share my lessons learned from my short work in this low value care space. And then I merely bring, researchers' perspective based on what I've learned from the data, but also it leads to the broader conversations at the end. So my brief introduction that I'm a health economist, and then what I generally do really well summarized in these cartoons say that at the pharmacy counter, pharmacists handed over medication saying the drug itself has no side effect. The number of health economists like David Kim needed to prove its value may cause dizziness and nausea. So I'm a health economist doing lots of cost effectiveness analysis and economic evaluations of new interventions, and then let payers and the decision makers help them to think about whether providing additional coverage for new interventions or new drugs are really worth the money. But what I've learned in the past few years that the covering only cost-effective intervention is not the only ways to improve healthcare efficiency. The reason why is that all of you know that lots of total healthcare spending goes to unnecessary, ineffective, overpriced, wasteful services. And we know these numbers, but I just put it in the context that the $760 billion waste in US healthcare system, actually more than how entire US spends to fund the K-12 public education. So that's the opportunity cost of like wasting money. That's where I kind of transition my work to think about, it's important to think about high value interventions and measure it, but also important to think about reducing those low value services that might improve the health outcomes at the populations and then improve healthcare efficiency. And I start obviously looking at what measures we need to look for, top 5 low value care. And then thankfully, all of your groups actually do the hard work to narrow down out of over like 400 and then continue to grow based on what we've seen earlier, a top 5 list of low value care. So I've evaluated many different low value cares, but for today's talk, I really pick up one specific example in a PSA screening as a low value care, and then to walk you through what I've learned from my work and the focusing on the PSA screening. And as many of you already know that a PSA screening considered low value for the older populations because the potential harms of a PSA screening, such as a false positive result, overdiagnosis, leading to overtreatment, are actually greater than the potential benefits of a PSA screening on the reductions in cancer incidence and cancer-related mortality. Also, like health economists, if you care about the economic side of unnecessary screening and follow-up services, in most cases, it's not worth doing it. But the problem I face is that, not that we don't know, since this top 5 list came out, there are numerous papers measure that there are prevalent low-value PSA screening use. So I like to go a little bit further, deeper down into, first, are the low-value care guidelines consistent and effective? Because why people continue to use it? And then my second question is that, is it like nationally consistent, or is there any variations in the use of low-value PSA screening, particularly at the state level? And then lastly, lots of studies really focusing on at the levels of initial low-value care. But as earlier presenter TD actually mentions that there are cascade cares that to what extent does the initial low-value PSA screening result in a subsequent healthcare services and utilization? So I like to share what I've learned on these 3 questions. So my first question is that, do low-value care guidelines provide consistent and comprehensive recommendations? So I looked at the PSA test for prostate cancer screening among men aged over 70, and there are multiple guidelines that may provide recommendations. And then I looked at the US Preventive Surgery Task Force, American College of Physicians, and then choosing wisely, actually, there are like 4 or 5 clinical societies providing recommendations for PSA screening. What I've learned is that all these guidelines are consistent, say, do not do this among the men aged over 70. But if you go into the recommendations and try to understand why they recommend not doing this, we call it like evidentiary rationale, and what kind of evidence they try to back it up, then it a little bit varies. For example, US Preventive Service Task Force clearly indicate that it's no net clinical benefit. Basically, the benefits of PSA screening didn't outweigh those risk of harm. ACP guideline, they actually go a little bit further that on the top of the no net clinical benefit, if you consider the economic side cost, then it doesn't provide any good value. So we shouldn't do it. For choosing wisely, because of each society making their own recommendations, their evidentiary rationale are actually varied. So at the top level, they're making consistent recommendations, but why we shouldn't do this are different. And I also look at PSA test for under age 70. And then US Preventive Service Task Force actually says it left up to the individual decisions at the patient clinician level, because they acknowledge there are some benefits to potentially prevent cancer incidents down the road, but also risk of harms exists. So you have to be carefully judged. But ACP actually still do not recommend PSA screening in this population. Their reason is actually, even though there are some benefits, if you consider economic side, it actually deemed low value. So for this case, since there is an inconsistent recommendation. Then my next question is, okay, that's great that we see some of the, at least at the high level, consistent recommendations. Then does the recommendations actually effective? So we conducted another empirical studies asking that, is the US Preventive Service Task Force guideline effective in reducing low-value PSA screening? So what we looked at is that we analyzed the Optum Labs data. So this is the enrollees in a Medicare Advantage plan. And then we use quasi-experiment, because in 2012, US Preventive Service Task Force updated its guidelines. Prior to 2012, they make the I statement, which means that they do not know there is a sufficient evidence. So I statement means insufficient evidence to make any recommendation for age 70 to 74. And then grade D for age over 75, which means that they do not recommend a PSA screening in this population. And then what they changed in the 2012 is that they maintain same grade D recommendations for age over 75. But they actually changed from grade I to grade D for age 70 to 74. So we felt like this is kind of interesting ways to look at these issues, that when US Preventive Task Force changed their recommendation, does it really make effective for age 70, 74, and in comparison to the age 75. So we conducted difference in difference analysis, but these are just the graph shows the trend, the prevalence of PSA screening in each population. So if you look at those age 70, 74, and probably if you look at right before 2016 in this graph, that you see that there are slowly kind of downward slope, not by much, a little bit. However, and then many studies actually evaluate short-term impact of the 2012 guidelines, says it does actually have effect. But when I look at actually long-term sustained effect, it doesn't have actually sustained effect. And then around 2016, the utilizations of low-value PSA screening went back up. So that might be only happened to age 70, 74. What about 70 over age 75 plus? They should not change any of their behavior because their guidelines are consistent prior to 2012 and after 2012. But as you look at here, they look at almost exactly same in terms of trends. Only difference is that just on age 70, 74 use more of a PSA screening, but otherwise it doesn't change the trajectory of the use. So what we found is that after initial reductions, both groups increased low-value PSA screening, and we found no differential effect of the revised guideline for MA plan enrollees age 70, 74. After this, we kind of a little bit really puzzles about why we are seeing this increase in a PSA screening around 2016. We try to look at lots of different explanations, but nothing actually came out kind of concretely or scientifically. But one way to look at it, this actually brought up from the earlier talk, that we actually look at the effects of changes in the patient cost sharing. So we basically look at the exactly same data, but we plot the average cost sharing for PSA test, and then it changes over time. So this is how much the patient's cost sharing level in a relative term for age 70, 74. So you see here that in 2010, it was about 4%, and it goes up to the kind of almost 8%. Then actually you see the downward slope in terms of patients' cost sharing. And then age 75, they have a slightly higher cost sharing level, but if you look at the trends in the shape, that they are pretty consistent. And then I I shaded the same areas after 2016 that you see that increased in the use of PSA screening. So I estimated based on those two data, the changes in the elasticity of demand. So elasticity of demand, basically, if how people actually responded to the changes in their out-of-pocket costs and relate to changes in the use of those services. And what I found is that elasticity of demand is like negative 0.82. What it really means is that if there is like 10% decreases in our cost sharing, then there is an 8% increases in the use of PSA screening. For age 75, if there is a 10% decrease in the cost sharing, there is like 6.8% increase in the utilizations for those age 75. So if you compare these numbers to kind of previous literature showing the average elasticity of demand for preventive services, it's actually much higher. General numbers like 0.43, depending on which estimate you're looking at. So what it means is that obviously all of those increase in the use of PSA tests is not 100% attributable to reductions in the cost sharing, but our argument is that maybe reductions in the cost sharing might be explain a little bit of those variations or increase the demand. Then we've learned that, yes, okay, so guidelines sometimes inconsistent and really not effective in a sustained long-term effect. Then my next question is that, okay, that's great, but how about like, is there any variations across the states? We've heard from Virginia and Michigan, and we've seen some of the regional variations from the certain states, but we leverage this Optum Lab data that has the 50 states data, even though they have a different penetration rate, but we'd at least take a sneak peeks of what's happening. So these are the low-value PSA screening across the US states. And then this is aggregate numbers from 2009 to 2019. So it's like 11-year span across. So I just like point out that New Jersey actually has a 42%. So basically 42 out of 100 eligible populations received the low-value PSA screening during this period. And then if you're looking at like Minnesota and Iowa, it actually has 1/10 of what New Jersey numbers. So only 4.2 out of 100 received low-value PSA screening. And one thing I like to highlight that because of changes in the recommendations in the 2012 for this state-level analysis, we actually focus on age over 75 who should not receive the PSA screening based on US Preventive Services Task Force throughout this time period. So aggregate prevalence was 27 per 100 across the all states. And then states in the top 10% perform actually 6 times as many low-value PSA screening as the bottom 10%. So there are substantial variations in the use of low-value PSA screening. How about the prices? Because we know that it's priced the stupid papers by Uwe Reinhardt, right? Saying that the cause of the inefficiency was the differential prices. And I thought that's interesting ways to look at it because, I just moved from Boston to Illinois, and then the PSA test, which is based on the blood draw, should not be different from the one I got from Boston than one I got in Illinois. So the price is, maybe a little bit different for cost of living. I don't know, but it doesn't make huge differences, my thought. And then it turned out to be, that's not the way. In Minnesota, the unit prices for PSA tests was $41. And then if you're looking at New Mexico and Florida, it's actually the $17. And again, we actually looking at the single payers data. The Optum Lab, it's managed by the single private payer. So it's not like different payers charging different prices. So the average price for PSA test was $24. And then the states in the top 10% pays the 1.8 times higher for low-value PSA tests. And then last piece is obviously the overall wasteful spending. So we all know the overall spending is the Q times P, how much you use it times how much you actually pay for the unit prices. So we look at the same things, and then New Jersey actually spent like $978 per 100 eligible populations on a low value PSA screening. So it's like $9.8 per 100 eligible populations. And then the New Mexico, which has a lowest unit prices as well as pretty low utilization, pays $80 per 100 eligible population. On average, across all states, it's about like $470 per 100 eligible enrollees, age over 75. And then there is variations that states in the top 10% spend 5.3 times more on low value PSA tests than bottom 10%. But as acknowledged that this is just looking at the point time that when they receive the initial low value PSA screening, and we know there's a care cascade. So this wonderful papers actually came out quite a bit in 1986. This paper defines the cascade care. So it says the cascade effect that we'll describe consists of initiating factor, which in my cases is actually initial low value PSA screening, followed by a series of events that seem to be direct result of a previous event, often catalyzed by some characteristics of the system, usually anxiety. And this chain of events tend to proceed with an increasing momentum, so that the further it progresses, the more difficult to stop. So I thought like this is perfectly applied to the PSA screening, because the initial PSA screening, once stopped there, it will actually trigger a lot more follow-up services. So we look at this. So we look at the cascading care of a low value PSA screening, and we examine the use of follow-up services. So population now, we look at the data from more recent data because there are lots of changes in the guidelines. So we don't want to look at the whole 10 years data. So we focused on 2016 to 2018. And then now we expanded the eligible population, because by that time, the age, anyone age over 70 years old, they should not receive the PSA screening. So in our data, we have about a little bit less than the 400,000 samples in a Medicare Advantage plan. And as you see here, that everyone start with the initial low value PSA testing. So I'm no longer talking about prevalence or how many of eligible population receive it. All of these individuals, close to 400,000 receive the initial low value screening. And over every 10 screened individual, at least 5 receive the one follow-up services. And then about like half of them actually receive additional PSA test, and then so on and so on. So if you think about particularly the psychological aspects of waiting that result, whether it's a false positive, and then whether you might have a prostate cancer, and then leading up to all the other things that consider, it has although we are not able to measure it, it has a substantial impact on patients' experience in life. But from the economic perspective also, out of every 100 screened individual, 7 receive the high cost follow-up services, biopsies, imaging, radiation therapy, and prostatectomy eventually. So we also try to quantify, how much actually cost associated with the care cascade. So we look at these things in the spending level. So these are like graph by each year, and then how much actually these follow-up services came after initial low-value PSA screening contributed to the overall spending or wasteful spending. So in these populations of a little bit less than 400,000 people, the spending for follow-up services actually substantially increased from 2016 to 2018. As I mentioned, the spending is combinations of increase in the quantity as well as the increase of prices. And then these spending actually drive much more from the increase in the use of the initial PSA screening, although the price increase over this period contribute little. So by the time when we get to 2018, there are like $11 million spent on the follow-up services. And then these are the key things that for every $1 spent on initial low value PSA screening, additional $6 was spent on follow-up services. So lots of existing studies talking about how much we are wasting on the low-value PSA screenings or any other low-value tests. That ignores the cascade care, but here we actually quantify that. So for the PSA testing, every $1 you basically spend total $7 that could be avoidable. So what are some key takeaway from my work is that even though in my previous 3 talk I used the PSA as an example, but we actually look at over 23 non-low value medication services because we know lots about low value medication, so we focus on low value medical services and procedures. But low value care is still prevalent, and then source of healthcare efficiency. From our data, $3.7 billion actually wasted from 2009 to 2019 across 23 low-value services and procedures. And as I shown earlier, the guidelines are also often inconsistent and ineffective in a sustained effect. When the multiple guidelines exist and then multiple guidelines tell different things, then it actually has a less effective in the changing individual behavior. And also, we show there are substantial state level variations. There are data limitations. This is from like single, health insurance plans data. But we found the substantial variations. And also there are particularly substantial variations in prices. So in the papers that I shared that we did a little bit interesting exercise that if average prices of 23 low value services that we examine in the top 10% of spender in terms of state were equal to national average. So basically if top 10% of spender has the exactly same prices as a national average instead of what they prices for, the overall spending in that top 10% stage would have dropped by 20%. And then this cascade care work are evolving, and then there are some researchers looking at these issues. We need to better understand these downstream consequences, not just on the PSA screening or the cervical cancer screening or EKG, but there are many other services that have some downstream consequences. So if I extrapolate what I found, that $1 spent on initial low-value PSA screening resulted in a $6 in additional services onto traditional Medicare populations based on the estimate, then basically $275 million in the traditional Medicaid populations spent on downstream consequences of these initial low-value services. So what I've learned from it and what we do. So basically, I was frustrated. I was excited to look at these issues and measures and then use econometric analysis, big data to understand these issues. But it doesn't seem that helping too much. And then my sense is that just the old behaviors that people keep doing it, and then a tendency to stick with the status quo make it harder to really disinvest and de-implement existing low-value services. So I felt like the single approach might not work in terms of reducing low-value services. And then we need a multi-concerted effort across the range of evidence-based solutions. And my take is that I was more focusing on the demand side, that looking at the cost sharing, but still low-value care to me, largely on the provider side. And then we should change the way that they get reimbursed and they're paid for provisions of low-value services. Many of you know that Mark draft this ACA section 4105 has a clause that the insurers may cease reimbursement for the services that graded D by U.S. Preventive Service Task Force. But very unfortunately, it's not like should. The term is not should, and then it may, which make it, I don't think any payers actually doing it. But that's one way to do it. Another way to do it, to me, that incorporating low-value care into CMS quality measures. I have another papers that look at the associations between cost effectiveness evidence and then CMS quality measures. finding that lots of the CMS quality measures focusing on process, like screening for the depressions or screening for testing for the HbA1c level, they have a very good cost effect, like good things to do. But CMS quality measure mostly focusing on good things to do instead of things that we need to avoid. So if we can expand the CMS quality measures to including things that we should not do, this may be the list from the low value care that we discussed earlier, then this could be tied to the Medicare share saving models as a part of a little bit indirect incentives for the providers make more better choices. Even though the provider factors are biggest influence, I do still believe that the consumer side also have some important side to address. But I think it's important to implement nuanced value-based insurance design. What I mean is that I don't think the patients responded to all low-value services. There are certain type of low-value services that patients may respond to their cost sharing because they have their discretions to whether take it or not. And low-value medications are probably a good example that fall on this category. And then there are low-value care categories that patients doesn't have a choice, like low-value imaging, low-value procedures. Even though we can change the level of co-sharing, they may not change their behavior. And then finally, importance of routine measurement and reporting at the state level. I think these are like, we talk about like measurement issues and transparency. That's great. And then also we talk about kind of this issue a little bit about kind of what is the definitions of value. And then from my perspective as a cost effectiveness guy, that incorporating cost effective evidence into broader definitions of low value is important, because there are so many waste comes out from no value, but also there are so many waste comes from low value that provided marginal benefits, but it's really not worth the prices that we pay for. So these are the supported from the Honor Venture and Autumn Lab, the huge project team. I'm really grateful for it. And then thank you so much for having me here.
Thank you very much, David. David, could you put up that last slide, please, before the acknowledgements?
Okay, will do.
And while you're doing that, we very much appreciate sort of the stepwise approach you took here and your 3 questions with regard to looking across the guideline groups and whether those were consistent. The second issue was a variation at the state level. Does that exist? If so, to what extent? And then the data on cascading. So that kind of 3-part approach is quite instructive for all of us. Thank you very much. I see Mike Chernow's hand is up first. Mike?
Cliff, thank you. And David, thank you. A comment and then a question. The comment is, I think this emphasis on cascades is really important. So many of the low value services are diagnostic tests. And in the waste calculator, by the way, there is a rudimentary way to capture cascades, but that's besides the point. I think calling attention to that issue is really important because it gets at the core belief that some have that more is better. And understanding that it's not just more is better, but you get into a system and a lot of things can happen. So that leads to my question, which is, can you comment about some of the health status effects? You spent a lot of time on the spending, but for example, you got to the prostatectomy at the end of your one slide that talked about cascades. One might think, oh, some of these low value PSA tests found prostatectomy, or you could say these low value PSA tests made people get unnecessary prostatectomies that they wouldn't really have needed. And there's a bunch of other iatrogenic illnesses that aren't necessarily related to prostate cancer, infections, and a whole bunch of other things like that. So if you could talk about the trade-off and the health effects of maybe these low-value services do occasionally pick up something that was important, and how that gets weighed against the iatrogenic illnesses and complications.
Yeah, so the great comments that first things that, we use the claims data, so it's kind of hard to tease out that what are the health effects, and then there's the limitations of data. In order to, when we are estimating it, in order to avoid that all the PSA tests might be potentially valuable for those who have the alleviated PSA level diagnosis. We actually excluded them from the get-go. So basically, in order to be eligible to receive this low value PSA test, we use the age criteria and then a diagnostic criteria, basically excluding that anyone has a diagnostic code for alleviated PSA test, meaning that PSA tests provided for that particular population may still be beneficial. But again, we still not fully capturing the persons that who might be still benefit from the PSA test and the downstream consequences. So you could argue that we are like overestimating the wasteful spending. So that's a limitation that that we like to acknowledge.
If I could say, I was going to argue you're underestimating the spending, because there's a lot of things that you can't capture that may have followed on from that test. They could have been bad and not necessary. For certain types of things, if you get an unnecessary test that gives you an unnecessary procedure that gives you an unnecessary infection, I've known people who, they had probably got an unnecessary imaging test and then an unnecessary biopsy, and then ended up with some, really serious medical problem related to having stuff stuck in them. But that's an economist's, not a doctor's interpretation of medicine.
Right. So I think the two things that I think that population-wise, we may include some population potentially benefit from the PSA test, in that sense that we might probably over including populations. But in terms of estimating cost, as Mike actually mentions, that we only measuring the service level. But if you include all those doctor's visits that associate with the interpreting that result, and then all those pre-ops procedures, then definitely the estimates of the wasteful spending we likely underestimating.
Good point. Thank you very much, David. Let's go next to Adrian Casper.
Yeah, quick question for you, David. I was wondering if you've considered using the same methodology, but not around a change in guidelines, but a change in language in either the national coverage or local coverage determinations. And specifically, if you did that kind of two ways, right? You could think about where the NCDs and LCDs are specific to a do not do versus they provide the indications where it's appropriate, right? You can kind of think of a flipped language. I think that would be a really interesting look at what's actually driving, and what a great example with PSA, think of one that's specifically we're going to see mostly in a Medicare population.
Yeah, all right, that's great suggestion. I haven't thought about looking at the NCD versus the local coverage decision, so we'll take a note of it.
Another level of analysis. You're right. Thank you. Let's go to Mark Fendrick and then Ira Klein on deck. Mark?
I have a quick comment I'd like to call out, not only Mike Chern all the time, but Beth. So the folks in the Congress asked us to estimate how much was spent on the task force D-rated services in Medicare, which we showed it to be $5 billion over 10 years, which both you and Mike scoffed at. Let's just presume that all of those D-rated services have a cascade multiplier similar to what David so rigorously found to be at least $6 on every dollar spent, which would take us to 30 billion. What's the number you need, whether it be in the sake of Medicare spending or percentages, which you and Mike don't like, the 2 to 3%? What's the number you think that would be the threshold that would get more attention to these low value care services, let alone the clinical issues that everyone's raised thus far? Beth, you could go first.
I'll jump in.
If you're willing.
I'm always willing to answer Mark's questions. I would say, Mark, that the pushback that I have gotten, and we have plans and employers on here so they can argue with me if they'd like, but when it's been in the 2% range, I pretty much get told that, those are pennies on the dollar. I would say that when we have started talking in Virginia about adding like the work that Mo was talking about earlier today, the waste, fraud, and abuse, we've actually been looking at adding some prescription work. And when each of those are in the 2 to 3% range, then I get told now we're starting to talk about some real money. So I would say, just from the reaction here in Virginia, getting to that double digit, that 10%, that gets a different level of attention.
Beth, just quickly, so if you can get to 10%, not by a single procedure, but by a set of procedures, then you call attention to the set. Is that correct?
That's my new strategy, Cliff, is to give them not just one tool, but a series of tools, and show them how, even if each is only 2%, that when we put the whole package together, it's quite significant.
I'd be interested in hearing maybe our employer types, whether it's PPGH or others, if they want to comment on that as well. But in the meantime, let's go over to Ira Klein. Ira?
Thanks, Cliff. Yeah, I'm going to go over to that population that's over 70 and bring out some potential conflicts, because, I think in the employer space, we don't really have this as a huge savings. But I agree with Michael Chernow about the cascade effect. One thing that's happened since we've moved from 2010 to 2020, which you see reflected on the graph about the uptake of more PSA testing as time went on around 2016. I've seen this. I don't know if this is what's going on, but in the medical community and in the lay community, you're seeing a lot of signaling regarding those patients who have prostate cancer, the emergence of some very effective drug therapies. And so now you have this lottery-like mentality of, well, I should be tested because now there's actually something you can do about it. It's not like 20 years ago when Uncle Mel got it and we just didn't do anything. Now we have actual real guidelines and real therapies. I mean, I was just at the NCCN annual meeting and people were up there giving cases about prostate cancer patients who were in their mid to late 70s. And indeed, if you have the right characteristics, including specific genomic markers, you're going to get really effective therapy. So I don't know if the element of hope and therapy is changing people's perspectives and ignoring the guidelines, even those professionals. And the insidious part about this, and this speaks to that state level chart, when you look, and it's not universally true, but the example was of New Jersey. Well, New Jersey's a relatively high income state. So now you have people who can afford to get testing, getting testing, and then of those few people that actually have a positive result, who get biopsied, then have high-grade cancer, have a prostatectomy, and have recurrence, they're the ones that can afford treatment. So then ASCO goes and looks at sort of social determinants of health, racial and ethnic disparities in treatment, and they say, oh, well, look at this. These people with lots of money get great care for prostate cancer, and these people with no money don't get prostate cancer care. So the problem is you have two different groups kind of going in different directions, but for a lot of subtle additive reasons.
Well, good point. It does call for revisiting the benefit harm ratio over time. That's a point well taken. Obviously, a lot of questions could be drilled down into who among the 70 plus population really can benefit from those immunotherapies and so forth. I want to jump to Randa and then come back to Chernu. Just a few minutes left. Randa?
Yeah, I was just going to say, the question around what kind of motivates employers around engaging in this. And I think where a lot of employers are on this topic specifically is really, while they do look to their plans, I think they're looking to advance primary care as a way to manage low value care and make sure that they are partnering either through direct contracting, on-site clinics, primary care networks that are really managing evidence-based care and making sure that they're providing high quality, whole person, equitable care. So I think that's really the direction. A lot of employers are wanting to redirect all this downstream spending into investing more in primary care, where a lot of these decisions are made.
Randa, is there, point well taken about redirecting those funds to something that's more effective? Is there something about some some bogey to hit, some target to hit insofar as savings we heard about before. We heard about 2% is different from 5% is different from an aggregate of 10%. In other words, what gets their attention if there is some bogey there?
I don't know if I know exactly the bogey, but I would say I think the comments are appropriate that were made, that it has to be a significant amount to really motivate. The benefits teams are really busy. And so I think that the dollar amount has to be something that they feel that they can achieve. I would just say, but we do have a lot of members that are starting to really, transparency and coverage data is out. We have hospital pricing data. They're really starting to just audit all of their claims in a way that's really having a waste, fraud, and abuse and an auditing department is starting to be more regular. And so I see more and more players interested in using data to identify low value care, no value care, and really manage their spend more aggressively than they have in the past.
Okay, so looking for the data at least, and I noticed Denise's comment about, I guess that target depends on the employer and how they define it. Point well taken, Denise. Mike, let's go back to you. Mike Chernow?
So a few reactions. The first one is, I think something Mark said early on should be reemphasized, that focusing on the health effects more than the money might be important, because employers will spend a lot on health effects that save no money, in fact, cost money. Look at disease management and wellness programs. So harm reduction may be a better sale than saving money. That being said, I find it astounding that, this is just, I say this as an economist, that it costs so much money to save money, so much attention to save money. I would have argued, and I said this in my previous comment, it is the carrier's job to figure out how to make sure that they deliver a product without a lot of defects. And if they do, they shouldn't be paid for them. And the employers shouldn't be the ones going in on the ground and trying to start initiatives where they're engaging with the delivery system. But certainly they could try and pay less for care that's not high value. And if the carriers don't want to do anything, the carriers, I believe, are the ones that should have to eat it. And if the providers don't want to do anything, then the providers should be the ones that have to eat the cost. And it may be we need to motivate it based on health instead of on cost, but to simply be able to measure it and say, okay, we're just not going to pay you for it, do what you want. That seems to me a relatively low cost intervention that doesn't require all of the complicated things that Beth was doing and that Aaron was talking about at Meritus, and they're doing things. That seems like something that at least an employer could say, we're only going to pay for things that we believe are valuable, even the gray area. We're just going to cut out the other stuff, but that seems to be hard to get to. So I feel like I've just gotten another chance to make the same old speech, and I appreciate your patience, Cliff.
Well, Mike, it's not to be lost though. How many of these employers would put up with this kind of inefficiency in any other aspect of their business, apart from the harms themselves to their employees? It's
trying to figure out, someone may know this on the call, so I'll ask this call broadly. I want to know if a grocery store receives a shipment of chicken that is 4% spoiled, who pays for the 4%? Who pays for this 4% spoiled chicken?
They probably turn the whole truck back. That's what I think happens.
Yeah, I don't know how that works.
Low tolerance. Well, I'm going to give David Kim back to you for any final words of wisdom, David, based on your analyses and or what you've heard. And here are the final messages you want to leave with us insofar as moving forward and drawing in particular on your cascade findings.
Yeah, so I think that my final take is that we need to do more of the experiment with at the field. That's what I like to hope to see more. That whether Mike mentioned that whether pushing providers more responsible for delivering services between contractor agreement between the payers and providers, or maybe like payment reform that eventually reductions of reimbursement rates from the 100% to 90%, 80% for the low value care delivered. So that's what I like to see. Thank you so much for having me.
Well, thank you, David. Very well presented. There's some certainly strong take-home points there. And again, you made strong points on guidelines, variation across the states, and the cascading. And we very much appreciate your suggestions about moving forward. And maybe have an offline conversation with Fendrick about section 4105 there. That would always be interesting. All right, thank you very much, David. Let's move on now to headroom. And we're going to go back to Virginia. And Michelle Rockwell from Virginia Tech is going to address removing low value care to create headroom for expanded coverage, the case for cervical cancer screening. So we've moved from prostate cancer cascade effects and so forth to using cervical cancer screening as a means to understand whether or not we can create some actionable headroom, as it were. So let's go over to Michelle, and I see her slides are up. So Michelle, you're on.
Thanks so much, Cliff, and thanks for having me. I've enjoyed very much the whole day and listening to everybody else. I would like to take credit for my title, but I don't think anybody would believe that I made up a title that uses the word headroom. So I feel really lucky to have recently collaborated with Mark on a cervical cancer screening study. I'm mostly going to talk about that today, but also a little bit about some other low value care research that I've been involved in. I'm meeting a lot of people in this meeting for the first time. So I thought it might be sort of fun to very briefly share how I found my way to low value care. I practiced for about 15 years as a registered dietitian. Maybe that's why I almost got stuck on the comment about chickens, the chicken delivery to the grocery store. I didn't finish my PhD until 2019, but I was doing mostly physiology research on vitamin D in athletes. So I'm showing you here, but I didn't love it. I knew I wanted to be working in healthcare research, health services research. It was hard for me to figure out how to make that jump. In fate, I guess it was fate, I was introduced to John Epling, who was then a member of the U.S. Preventive Services Task Force. He had just moved to become a faculty member at Virginia Tech, where I am. And the task force recommendation on vitamin D screening had come out the week before. And we've been working together ever since. But in that first month of us working together in 2017, he emailed an article to me, and it was this very paper. And I think you'll recognize a lot of the names on it. It was the first time I ever heard of low value care. And I think I read all the words 3 times. So I've been able to do some more vitamin D and vitamin D cascades work, but mostly it was a neat venture for me into low value care work, healthcare delivery research, and it's been a fun full circle because I've been working throughout COVID with every single one of those authors on an APCD analysis of low value care, clinically appropriate care during COVID. I'm not talking about those findings today, but I love the story, so I thought it was fun to share.
And thank you for sharing it. It's so interesting that vitamin D was indeed your portal into low value care. So fortunate for all of us.
Now I'm going to call it a portal. That's even better word. So cervical cancer screening. Cervical cancer screening is a really effective manner of reducing morbidity and mortality from cervical cancer. But the part of the process that's required and isn't always followed up on is the follow-up care that happens after an abnormal cervical cancer screening test. So I was more familiar with someone has, for example, a stool-based colorectal cancer screening test. If that's abnormal, we need to follow up with a colonoscopy. I understand that process. As a dietitian, I worked with that. I very much appreciated all of the advocacy work that has gone into increasing coverage for that follow-up colonoscopy. But it was new for me to learn more about the need for follow-up colposcopy. I had never experienced a colposcopy. I put together a research team. One of them was a gyn-onc physician at Crellian Clinic. She let me shadow her for a whole day of colposcopies. I probably didn't need a whole day of it, but now I know exactly what we're talking about and why it's so impactful in reducing and preventing cervical cancer. A problem is that only about 50% of women who have abnormal cervical cancer screening, pap smear, HPV co-testing, have the necessary follow-up colposcopy to be diagnosed with cancer, and less than half in many disadvantaged populations. So that's a big deal. It completely undermines having the screening in the first place. We just know if somebody might have cancer. A very commonly cited barrier to having the follow-up testing, of course, is cost. Mark has done some previous work with another team showing that the cost of that colposcopy, first of all, it's common. 80% of commercially covered individuals have a follow-up cost, and that ranges between $20 and up to $1,500, usually around $155 on average. So the Affordable Care Act requires coverage of the screening test, but not the follow-up colposcopy. That led us to look, using the APCD, at commercially insured Virginians. We used 2019, so we would have a pre-COVID year. We wanted to look at the cost of colposcopy, so those follow-up tests after abnormal screening tests. And there's probably too much on this slide, but if you look at the turquoise numbers, you can see the total costs, the payer cost, and the patient costs are about $7.5 million altogether for 1 year, about $144 per patient. One of our co-authors for this project has done some interviews with patients, and over they say if it's more than a regular copay, $25 or $30 is what they keep saying, they're not having the follow-up test. So we saw an average of $144. I can't imagine that payers would be very enthusiastic about picking up this $7.5 million tab, understandably, but I think you would really know that this was Dr. Fendrick's idea if I started saying things like robbing low value Peter to pay high value Paul. But it does seem really logical that there's enough money there. We can reallocate spending on low value care that doesn't need to be happening, might be harmful for something very valuable like this 7.5 million. So we looked during that same 2019 at low value cervical cancer screenings that happened in Virginia. And low value screening, I have the general criteria for that shown here in this box, but generally it's in women who are under 21, who are older than the age recommended for screening, or typically the screening was occurring too frequently. So the recommendation used to be, for example, screening annually, and now it has changed to generally every 3 years, with some methods, sometimes 5 years. About a third of the screening tests in 2019 were low value, with a cost, of course, an estimated cost of around 4 million. So that 4 million doesn't cover the whole tab of the 7.5 million for patient cost of colposcopy, but it sure covers a lot of it. So we're really excited that this is a great example of how low value care in the same service, that expenditure could be reallocated to a really productive high value service. I was excited to see a few hours ago that Mark sent me a message that our paper was it was published online last month, but the real publication is out now. So that's all I was going to mention about the cervical cancer screening study in particular, but I've been hearing about the Create Headroom for High Value Care. It's made intuitive sense to me. It's informed a lot of the research we've been doing, but it wasn't really until a project that we've done over the past 2 years that it very much clicked in the work that I've been doing. Of course, if we aren't paying for as much low value care, the finances make sense. But it was insightful for me to see the impact on capacity. And that's been mentioned a few times throughout the day. I won't go into too much detail about this, but nationally, there's an issue, particularly coming out of COVID, not enough institutional capacity for screening colonoscopy, for screening for colorectal cancer, as there is demand. And there are a number of solutions for that. I think a really important solution, of course, is reducing the low value screening colonoscopies that don't need to be happening. In our institution, 1.5 million patients regional health system, it's about 30% of the screening colonoscopies are low value. Nationally, we keep seeing studies showing around a quarter of them are low value. But when there's such a capacity issue for 2021, 2022, you can see how many were completed. This is just within our health system compared to how many were ordered. It just seems really glaring that if we can get rid of those tests that didn't need to happen, we open up system capacity for the patients who need to have screening. It means that the wait time for a screening colonoscopy goes from 10 months, 11 months, which we keep hearing throughout the state, to a more reasonable place. Several people have talked about clinician capacity that increases when we aren't doing as much low value care. I think Erin was the first one to mention that today. As we interview clinicians, there's so many who get that and say things like what Erin said. If we order fewer tests that aren't indicated, that means fewer tests come back to us and fewer cascades we're then dealing with. And capacity for the patient. So as we have surveyed and interviewed patients who have completed the colorectal cancer screening process in the past year, those who have multiple chronic conditions, especially those who have 5 or more multiple chronic conditions, rank the highest on the burden of getting screening tests because they talk about all of the other healthcare that they have to seek out. So if we can scratch off the list these low value services that don't need to happen, hopefully it makes more headroom for them to get the really important high value screenings and treatment.
Michelle, you can't leave this slide without saying why you came up with the phrase at the bottom in bold.
Oh, I did skip a really good part. Yeah, the framework, was that you who said that, Mark?
This is
Cliff.
Cliff.
Said that? Sorry, I should say that part. The framework that informed our colorectal cancer screening work was SLUDGE. SLUDGE is a behavioral economics term that describes frictions or administrative burdens that stand in the way of someone getting what they want or need. There's a 2020 book by Cass Sunstein that popularized the term sludge. But when that book came out, we were just starting our colorectal cancer screening work, and it really made sense to me that if we can reduce low value screenings, create more capacity, make it easier for people to get the screening colonoscopy they need, not 10 forms that are redundant, having to drive back and forth far distances, getting instructions that don't make sense, all the sludge, all the administrative stuff. If we can peel that away, it especially makes screening colonoscopy more accessible to the patients who need it. But another neat side story is I thought that for sure that Cass Sunstein would find this work so interesting. So I emailed him and he wrote back in about 6 minutes and has been working with us on this project and is really invested in it. So that's been an especially fun part of it. But we think low value care goes very much along with sludge. It's making it really difficult for people to get the care that they need. So I'm showing you just one little piece of a sludge audit that we did to identify sludge points in 2 health systems in Virginia, and we're trying to expand that beyond that.
Well, Michelle, thanks for doing that. One reason I raised it was, in addition to sludge in economics these days, there's also nudge. And I think Cass Sunstein would be among those who could speak to that too. So nudging and sludge are not irrelevant when it comes to looking at low value services.
Indeed.
Thank
They're
you.
sort of opposites, in fact,
Yeah,
right?
We can come up with a way to nudge people in the direction to limit low value care services, we could eliminate a lot of the sludge in the system. But in any case, I'm so glad you hit on that term. Thank you.
Also, don't you think sludge is a good word when you're talking about colorectal cancer screening? I think they kind of go together in
If you
an
want to
icky
get
way.
clinical, sure. Thanks.
So the last thing I will mention is it's been, as a newer health services researcher, it's been a pretty terrific experience to get in the trenches, in practices, to really talk to clinicians and practice managers and nurses and dig into why is the low value care happening and what can we do to make a difference. And I was sort of nudged in this direction by Beth Bortz and her Smarter Care Virginia program, which I imagine a lot of people in this group have heard about. But Frillian, the hospital that I collaborate with, the health system, 45 primary care clinics in Southwest Virginia, is one of several health systems participating in Smarter Care Virginia. We're working to reduce 10 low-value services statewide. I mostly work with primary care. I got leadership engagement with reducing low-value imaging for acute back pain. I think the biggest reason why they were engaged, two reasons. They saw the data that we were able to share from the APCD that was provided to us by Beth and VCHI. And also coming out of COVID, we had really long waits for MRIs. So it appealed to them that if we can get rid of some of these that don't need to happen, that we could make room for the patients who need to have them more quickly. But also coming out of COVID, no one in the practices had much bandwidth for anything. I was never going to be able to pull off a major or intrusive intervention. So we rolled the dice with a really low burden one. The practices every month have a quality improvement meeting. It's called a quality improvement meeting, but mostly they're talking about strategies on how to do more, how to achieve their CMS metrics, how to enhance their dashboard and scorecard performance. It's all do more things. It's all increase high value care. None of it has ever been reducing low value care. So we created brief 3 to 5 minute modules focused on imaging for low back pain. I loved seeing some of Denise's materials. We'll use that as we work to disseminate and expand this intervention. We delivered those at the end of the quality improvement meetings that were already happening. We also shared some other educational materials. We shared a smart phrase for the EMR, some materials that people didn't already know about, videos and handouts that already exist in Epic. And we gave clinician performance reports. I'm showing you a not big enough version of the template that we made, but our clinicians now have gotten used to having this emailed to them. Every 3 months, they get their report. And if they see me, they'll sometimes talk about how their score has gotten better. With it not being tied to their paycheck or to a formal incentive, that has actually been a positive way to introduce it. We specifically delivered the intervention to the bottom 6 performing practices out of the 45. There was a dramatic difference in the top performing practices and the bottom performing practices. Before we started this, it got a little out of order. We surveyed the top 6 performing and the bottom 6 performing practices, thinking we might be able to learn a lot about why are some clinicians and practices doing really well? Why are some not? We also thought, as others have shown, that it might be the folks who have X-ray or radiology in the clinic are the ones who are ordering a lot. That really wasn't the case at all in our data. All we could see in the survey, and it was pretty glaring, the clinicians in the poorest performing practices had a lot of comments about patient demand, how they don't know how to explain to patients that it isn't appropriate. They feel like their patient satisfaction is going to go down. It felt like their interaction and communication with patients was night and day different than the clinicians in the best performing practices. Everything else seemed very similar. So 2 of our 3 modules have really focused on that and even include a little role play. I will mention that we've just finished the 9-month data analysis, and we're 1 month away from the 12-month period, and the intervention practices have reduced back pain image ordering, the low value ordering by 21%. So it isn't crazy huge amounts, but it's 21%. And the top performing practices have also decreased by 2 or 3%. We have some control practices that have stayed almost exactly the same. So I'm really happy about that improvement, but I'm also happy that now there's been attention called to part of opioid deprescribing in our region has been associated with a big increase in low value NSAIDs, and the go-to from leadership and some of the managers is, well, let's do the same thing we did for back pain imaging because it seems to be working. People are listening. We already have a format. So I hope that's a way that we're talking about low value care as if it's a quality metric, just like the high value care that we're talking about. I want to finish by mentioning the part of this survey that we did that I found the most interesting and I keep thinking about. I really want to study it. We had the clinicians rate a number of things, including their agreement with the Choosing Wisely recommendation to avoid low value imaging for acute low back pain, except for in certain high risk scenarios. They largely agreed with that. The mean was 8.9 out of 10, 10 being completely agree, 0 do not at all agree. But when we asked them how much they trust the performance data that we provided to them, the average or the mean was 4.4 out of 10. They really don't trust the data. So we've done a series of about 28 interviews talking to them more about why don't you trust it? What sort of messenger or format would you trust? What would make you trust it more? So I need to find time to really analyze that data, but I think that trust area with data is really an important area to move us forward in low value care research. So thank you so much for the opportunity to finish off the day. I would love to try to answer questions.
Well, I want to kind of set up your state colleague, Beth Bortz. Beth, having listened just now to Michelle in your favorite state, we have today been exposed to a whole variety of ways to make the argument. And we've been exposed to a whole variety of ways to try to implement and try to, if you don't mind me saying, nudge people in the right direction. So what would you say that, having just listened to Michelle, Beth, has Michelle brought to the menu or taxonomy of approaches you would take in the state of Virginia? Beth? And by the way, I'm putting David Kim on the spot too. David, I'm in a few minutes, I want to ask you to reflect on what Michelle just said, insofar as whether you would want to perhaps pursue cervical cancer screening from the standpoint of cascading effects or other impacts, and whether that would be data doable. So David, you're kind of on deck to answer that. But Beth, can I call on you?
You can absolutely call me, Cliff. And I will just say, first of all, yay, you can all see why we're doing well in Virginia, because we have rock stars like Michelle who get engaged. And I would say that Michelle is a perfect case in point on how I think this works, because Carilion brought Michelle to the table, I believe, when primary care at Carilion didn't think they had a role in Smarter Care Virginia. They weren't very interested. They didn't think they could make an impact. And Michelle was the one at Carilion who raised her hand and said, well, let me see. Let me see that data. Let me see what we can do. and, just really got the ball rolling. And so I think very much that there is a significant culture change that is a part of this, and that culture change starts small. But when you get folks to feel like they have some ownership of this, and that they can, that they're not going to get pinged, they're not going to get shamed, but there's an opportunity to engage, really great stuff happens. And so that's why I've moved a little bit closer in the Mark Fendrick camp of, it doesn't have to be huge out of the gate. I mean, you have to be able to get them to the table. But once they get started, they just, you saw Michelle's just keeps adding, at Carillion to the things. And I think that's the really important piece.
Well, it just seems at this point, Beth and Michelle, that across the state of Virginia, which by the way is an extraordinarily diverse state in and of itself, if you move from the Atlantic shore all the way to the mountains in the Southwest Virginia, that is a lot of diversity there. It seems like you have developed kind of a homegrown set of data sources, analytics, and ways to take action. And it would seem like that could be persuasive across the state, and people could maybe sort of customize or retool an approach in any given community hospital versus, a large employer versus other kinds of stakeholders there. So hats off to Michelle for that, certainly to add to that.
I would just say one thing on that clip, for our Smarter Care project, we had monthly calls with the leadership teams of all 6 participating systems. And one of the things that I have discovered is that, those were folks that didn't have relationships before the project, and they get really excited about sharing what they're doing with the other systems, and it's not competitive. And it's been very collaborative. In fact, just while we've been on here, one of the surgeon, Dr. Luchtong from Carillion, just sent me a paper he's submitting on what he's been doing with Carillion. And, he had Inova look at his paper. So it's just created this whole community of people excited about the work.
Sounds good. Thank you. Before going back to, Michelle, did you have a response, by the way? Go ahead.
It's tiny. I was just going to say, it's been neat to talk to people all over the state. I'm one of the people from the mountains of Southwest Virginia, but I was at a conference and someone was presenting about their Smarter Care work, and they showed the performance reports that they're giving. And it's the one I made, the one that my medical student and I made, which, we've been sharing around, but the exact same thing with the different logo on it. So it has been a way to learn from each other.
That's great. Thank you. Before going back to David Kim, want to jump over to Gwen Darian. Gwen, your comments.
Hi. Whoops. Thank you. I'm having an allergy attack. Excuse me. I've got a thing in my mouth. So I wanted to add another facet to this, and this was really wonderful, really interesting. But I want to also add the kind of patient lens, patient focus, patient advocacy focus, and also the notion of culture change. Talking about culture change within the healthcare system, but there's also culture change between the interactions between healthcare providers and their patients, which we can't forget about. And often in this forum, often in this task force, I bring up the idea that we have to reframe some of the things we're doing with low value healthcare from withholding care from patients, which is how they see it, to reducing harm for patients. And so we always hear a lot about, physicians having this challenge because they talk to patients, and patients think, they combat them and say that, I don't want that. I want that test. I just want my test. But part of it is the way that this communication is done, which is that you have to lead with reducing harms, not lead with taking away a piece of care. And I think that is I think that makes a huge culture change there. And then the other thing I was really struck by was one of the other things I was really struck by was that we were talking about trust, and that a lot of the some of the healthcare providers didn't trust the data. So how can patients, if whether they say it out loud to the patients or not, you can feel when somebody doesn't trust. So how do we address that? I mean, I have gone from the patient side because I'm a pretty well educated patient and advocating for myself and others. I've gone in and had conversations with my providers about, I don't need that. I don't need that test. I don't need those antibiotics. I don't need this. I don't need that. And so I will say in many forums, I'm challenged by healthcare providers. Why do patients always ask for things? And I think that patients don't always ask for things. I think that often it's the healthcare providers that's pushing things. And then on the other side, it's the reframing of the discussion. So it's really about reducing, I want to reduce harm for you. This is why I'm suggesting we don't do this test. We don't do this test because there's no evidence to back doing that test, but emphasize what are the harms of low value care and over testing and over treatment.
Thanks very much, Gwen. Michelle, any thoughts about that and making the case on the harm side of the scale?
Just that our clinicians have very much provided the feedback that communicating that we used to talk a lot about this is the right care. We're not trying to hold that care you need, but we're trying to give you the right care. That wasn't really effective. They didn't feel that it was effective. Those who have said this could be harmful, they get farther with that. We've also heard from patients that they feel a little more open to their clinician's recommendation, even if it's different than what they might have thought during COVID and coming out of COVID, because people don't want to be out as much obviously we've come out of that a good bit, but they're more open to hearing you don't need to do that.
Yeah. Okay. Point well taken. I think that theme is coming across more strongly. Yeah.
And
Gwen, did you have a quick take?
Yeah,
Sure,
I had
Gwen.
a quick follow-up, which is I had shared this paper before, but in the early days of choosing wisely, because we've gone back to choosing wisely in this project, because the outreach and dissemination messages were about reducing kind of excess expenditure and fraud and reducing waste. And those were not effective. They did not have an uptick. But when there was work done on looking at why this reducing harm provided, that was a much more effective way of engaging patients in helping to reduce low value care.
Sounds good. Thank you, Gwen. David Kim, I want to just go back to you because I know you were listening to Michelle's presentation on cancer screening, then she got into low back. How do you reflect on what you just heard in light of the context that you presented? David?
Yeah, so I think it's absolutely great. And then I think that this forum that we all agree that it's really important to look at, not just the point of the care as a low value, but also, kind of downstream consequences as a care cascade, and cervical cancer screening and low back, those are kind of pure examples of having lots of subsequent cares and then costs. So it's important to measure that. And I think I encourage you to measure those things that kind of in the similar ways that I did, or there are many other people who are doing similar work in this area. So you can follow it. I think that the two things that I like to add it on to that. One, identifying, potential individual, we call it like false positive, but you label them as the, low value care patients, but it might be actually benefit from this screening and services. It came out during my conversation. It's extremely hard to precisely identify these patients without access to electrical health record or the detailed diagnosis or conversations happen. So that's a limitations of claims data. But when we moving on to the single low value care from cascade care, then it's really important to look at among this cascade care, which individual who actually benefit from. So it's not really low value. They actually receive the necessary follow-up care versus, all this follow-up care should be avoided and then unnecessary. So I think differentiating these two is a challenging. And then another thing is that I heard a lot of discussions about we are moving from like low value care to like harm reduction, kind of focusing on the health side, which is great. And I briefly touched on my talk. And then also Mark Chun-Yu actually picked it up in his comments that it's really important to consider spillover health effects on the caregivers and others. And then not just on the receiving of this screening, but there are substantial distress, anxiety related to the potentially false positive, but even it's true positive, it has an impact on their mental health. And then in the economic evaluation literatures, there are more studies coming out to measure how the positive test affect their health-related quality of life in the short term, measures in the health-related quality of life. So I think that I didn't include that, but kind of broadly thinking about, who actually impacted by this screening, not just on the utilization cost side, but also health side would be important areas of future research.
Good. Thanks very much, David, for reflecting on that. And I'm wondering, Michelle, back to you, in sort of a reverse reflection of David's presentation, to what extent did you sense that there's any sort of disquiet or ambiguity regarding guidelines for cervical cancer screening? Does that introduce error or ambiguity into the system? And furthermore, anything having to do with, are there cascading effects on the upside or the downside with cervical cancer screening? In one sense, for those patients who are indicated for cervical cancer screening, if they do come in for that, that is an opportunity to look at some other aspects of their health, particularly people who are subject to disparities and inequities. It is a good sort of opportunity to kind of check into social determinants and other health needs and other social needs. I'm wondering about sort of the expansive cascading either way, if you have any thoughts on that as well. That and the guidelines disparities, if any. You might be you're good now.
Can you hear me okay?
Yeah, come on. Yeah.
My mind is still thinking about all the interesting things that David said that I was just catching up with. And then you asked two really good questions. No, I will share that when Mark and I were first talking about doing the compare low value spending to colposcopy patient follow-up costs, I started with pulling together a group of collaborators who know more about cervical cancer screening than me, treatment of cervical cancer, and cancer billing and coding and so forth, in addition to working with VHI on the data. It took us a few months to just get everybody on the same page, and we even lost 2 people from the group, not in any sort of uncomfortable way, but we weren't going to get on the same page about, some people don't support all of the guidelines. So there was controversy, and you captured exactly one that what was the biggest, that not everybody agrees with the guidelines, and having patients come in for cervical cancer screening gets them there for other care and other conversations that they need, particularly around women's health. So I'm just acknowledging that that one was controversial, not as much as when I've done some work with vitamin D, where nobody can get on the same page, and that probably got worse with COVID. But more so than something like back pain imaging, where almost every clinician that I talk to agrees with it, or at least in theory. So I'm acknowledging that it was tricky in that regard. And of course, the recommendations are evolving rather recently.
Michelle, what other insights can you offer insofar as, because we've heard a bit about this today, really small group one-on-one interaction with clinicians to make these cases? It seems that in your experience, there was some of that. Any further comments on the utility of interpersonal interactions and whether it's competitiveness or data sharing, thinking at the personal level, thinking and acting at the personal level?
The interpersonal interactions have been really important in the health system that I'm working in. I noticed that Denise said in the chat that clinicians she's worked with have trusted the
We
data,
did see that, yeah.
but they like competing with each other. A lot of the clinicians about our performance reports are saying things like, just send everybody's out to everyone, or let's have a practice-wide score sheet. And that isn't the approach that we want to take, but they talk to each other about it. They're competitive in spirit, and them designing it that way and them taking it there has been helpful. I've definitely grown to appreciate how much the individual time with clinicians, especially the naysayers, matters. So the clinicians who don't believe we can find anything of value in claims data. For the Smarter Care Virginia project, we actually reviewed all through the 9 months. We also reviewed data from EMR. We chart reviewed. I have research assistants who have spent, 400 hours now. We're finding slightly more than in claims data, and then the health waste calculator picks up, but it's a fraction. It's about 3 or 4% more. It doesn't matter. And when I sit there one-on-one with a clinician and we go through their list of patients, they're like, you're right. It does, I forgot about those, or, but that time is really valuable. And I think, as Beth was saying, it does change the culture for more than just that one measure, but it's slow and it's hard.
It is slow and hard, but it does seem that we're adding to the tools that we can draw on to try to make the cases here. So any further comments on Michelle's presentation? Any further insights to add at this point? At this point, not seeing, had a bunch already. So Michelle, thank you very, very much. This shed some additional light here. And the cervical cancer screening is just chock full of examples on how to make the case in a strong way. Thank you for that. I'm just looking over my notes here, and I've got to say, as I kind of look across our half day here, that, gosh, just starting from the beginning, Denise gave us a great insight and update on the opioids and the back pain issue. That was rather illustrative, I must say, of a few points. Mo Saeed really shed some light on the kind of the evolution of APCDs and analytics to make the case. Very much appreciated. Really like Jason Spangler, remember that he talked about no value without equity. Thank you very much. I'm going to remember that. Aaron George talked about what's going on in one particular health system and how he's going to transplant some of that out to Western Maryland. He really emphasized this whole sort of set of ways to make the case about reducing unnecessary utilization, diminish harm, diminish length of stay, diminish staff burden, diminish time in the EMR, diminish resource use, diminish global costs. I think he also showed very nicely a very good process for operationalizing how to go about these reductions in a healthcare system. He had the data atlas, the driver diagrams, and so forth. Thank you very much to Beth Bortz, who gave a great report on the ARC conference grant for the advisor committee, a la the Barbara Starfield event, and insofar as how they, and with the help from Beth Bodan-Seiler, went through a series of kind of steps, adaptive steps, I might add, to come in a strong collaborative approach to come up with a no value list. They went from hundreds to 72 to 31 into something smaller. Also pointed out nicely how they took account of the various kinds of concerns, almost again, a taxonomy, a categorization of concerns to accompany any single member of a no value list. That's always very useful for demonstrating your transparency of your process and that you're hearing people. Adisen talked about the 10 most frequent low value services, the 10 most highest spending value services, and then the kind of Venn diagram of 7 that are on both lists, where 7 low value services account for 70% of spending loss. That's not a waste, I should say. Not even accounting for cascading effects. And she really made clear why it's hard to do this, but that Venn diagram, I think, is very good, is going to be very helpful along the way. Again, 7 accounting for 70%, is just like the thing Jason mentioned about value and equity, kind of slogans to remember. David, Kim, thank you very much for taking a look at prostate cancer screening as a very helpful way to demonstrate aspects of guideline, lack of guideline consistency and the impact that may have, looking at variations in across the state in low value care services, and the whole cascading issue, the cascading impact. I think when you talked about the ambiguity across USPSTF, ACP, and choosing wisely, those kinds of differences kind of point out to people, or kind of cause some uncertainty in people about following through on these. And I think that your proposed reforms of payment policies are things that we want to kind of revisit. Can we still use selectively certain payment levers to bring about this change? Very, very helpful. Michelle, as we just heard, came through, as I said, the portal for vitamin D. Interesting that was the way that you bridged your nutrition world with the world of low value care. I think that showing how abnormal PAPs lead to follow-up colposcopies, when they do lead to those, when they don't lead to those. I think you said about half of women with abnormal tests don't get follow-up colposcopies, which tells you about some headroom there. And you actually came up with some helpful figures showing that toward the 7 million that it would cost to get everybody those follow-up colposcopies, as indicated, you could generate $4 million in trying to avoid unnecessary services. So that was very, very helpful. Want to thank Gwen and others for pointing out multiple times the aspect of reducing harm. I think that resonated very, very, very strongly today. So many, many, many messages here that we came across. I think we are at kind of a crossroads here about where do we go next with all this information. We've come at this from so many angles about why and how to go about why we have low value services, how we track those, proposed ways for reducing those. We have developed, as I said, a taxonomy of approaches to try to address this, but now might be a good time to sort of reevaluate where we are and take some necessary next steps. Before I go to Mike Chernow for some final comments, I'm going to call on Mark Fendrick, whether he wants it or not. Mark, any day-long observations here and or looking ahead? Mark Fendrick?
Cliff, thank you. I'm going to leave the final word to Mike, but here we are 13 times around. We make incredible steps forward on these issues every time. Your summary is just superb. Mike and I always feel lucky that we don't have to do it ourselves. That was amazing. I just want, you might remember the first meeting, I quoted Upton Sinclair, the book from the jungle. It said, it's difficult to get a man to understand something when his salary depends on him not understanding it. And you mentioned the top bullet on David Kim's slide, which is also the top on mine, that as someone who's devoted 30 years to consumer-facing initiatives and cost sharing and benefit design, I feel now, having looked at low-value care for almost 15 years, that this is not a consumer problem. It's largely a provider-facing problem, and how we need to work very hard to change those incentives. And as someone who's provided a lot of cervical cancer screening and never received one, I've never met a patient who wanted to undergo cervical cancer screening if the evidence or a clinician told that particular person that they didn't need it, which is why I felt that when asked by so many members of this actionable group to give a real example of robbing low-value care Peter to pay high-value care Paul, they said, if you build it, they will come. And I challenge not only the attendees that remain now, but those who work in the payer community and will listen to Mike and decide to make providers accountable, that we actually can really do move the money around and improve clinical outcomes, improve equity, and not spend any more money. And adding on top of that, the term harm reduction, because there are cascades that come with cervical cancer screening that we could hopefully avoid. But to close where I always start, is we do low value care so we could provide more high value care. And some of you might know that, you know, my top personal priority before the Braidwood case was announced is clinical efforts to close this cancer screening coverage gap. 4 cancers for which the first screening test has to be free: breast, cervical, colorectal, and lung. We've showed empirically that Michelle mentioned that every one of these cancers are people who test positive, which is why we're screening for the first place, have to pay non-trivial amounts out of pocket to find out if they have cancer or not. I view that completely against the spirit of the law we helped write. And the fact that Michelle, in her very rigorous empirical work, can in fact show that we could subsidize almost all of the follow-up care only if we just stop doing the things that were non-concomitant with guidelines. Nothing else, no price changes, no network changes, no shifting site of care, gives me continued optimism moving forward. And when I invited Michelle and David in particular, I told them that we don't follow the publish or perish thing. We published and we still perished. And we rely very much on you, the members of this task force, to make things happen. And if it weren't for people like Beth and Denise and others who've been with us from the beginning, we wouldn't still be meeting. So I thank everyone on this call, all the presenters. I'll let Mike formally close out the meeting, but I'm excited that we're continuing to move forward, and we'll pick up part of the mantle from Choosing Wisely as that national effort goes away. Mike?
Thank you, Mark.
Yeah, so, I was supposed to say thank you, which is obviously the best job, and then wrap up after Cliff did a better wrap up than I ever could do, and Mark did a better thank you than I'll do. So let me just do a not as good job as them. So I want to really give my sincere thanks to Silas, Martin, and Jansen for their support of this. It's really unbelievably important to help make this happen. I can't explain enough how much work goes into organizing and making all of these things happen. And I've really been unbelievably impressed with the day, and to Sammy Doherty and the rest of the team at Pharma for the support that they gave to support this exercise. They have been continued supporters, and I think that they've really helped us create something that has been special. I will thank all the speakers. Since Cliff wrapped up what they said, I'm just going to thank them by name. I'd like to thank Aaron and Beth and Aditi, David and Michelle. They really hit the nail on the head with all of their presentations, and maybe I spoke too much after. They should take that as a compliment. But in any case, the meetings are good because the speakers are good. And the speakers are good. They are better because Cliff is good. I texted Mark in the middle some version of, I don't know how Cliff does it. Mark tested me back some version of Cliff is very special. So there we have it, Cliff. We could not thank you enough for all of your help and what you do to make great speakers greater and great meeting even better. As always, you're spectacular. And of course, the people that do the real work of making this happen is Susan Lynn, or Slow as we know her, and Jordan, who do a spectacular job of getting everything to work on time and to work technically. So again, to Slow and to Jordan, thank you so much. And lastly, I want to thank you all, the audience. Again, the reason why this is important is not just because of who is speaking, but is who is listening. And the group here that listens and then contributes is spectacular. I could not be more grateful to all of you who came and contributed, the new members, the old members, and the everybody in between. So again, we're going to have another meeting in October. You can contact us at vbidhealth.com. Please follow us on Twitter, follow Vivid Health on Twitter. And I wish everybody a wonderful evening and a great weekend in a few days. And again, I hope it was as useful for you and as interesting for you as it was for me. So with that, thank you. And please, please stay in touch.
Thank you, Mike.